wound cleansing and irrigation techniques. Will help. It will also help us in selecting the appropriate closure methods for the wound, and we'll know something to know about. We'll also know something about how to manage certain mammalian bite wounds. So moving forward, we'll start with a case scenario. So suppose you receive a patient who is a 32-year-old man with 5 centimeter laceration to his right palm, which was sustained 4 hours ago while working with a broken glass. He is a diabetic and he is taking medication by the name aspirin. The wound is contaminated with dirt. So for us as an emergency physician, it's a very common presentation of a wound. But if you see in this history and in this examination, there are multiple important aspects that we need to see. First thing, that this wound was sustained, a time is given which was 4 hours ago. Second, the patient is a diabetic patient, and also the patient has some comorbidity because of which he is taking aspirin. And when we look and examine the wound, the wound is contaminated with dirt. So what we are going to do now is, we'll learn how these important aspects in the history and examination help us how to manage this wound further. So what we can do bedside is, we can apply something called as HEAL approach to the wound assessment, where there is first thing, the history, where we see what is the mechanism of the wound, when was the wound sustained, whether the patient had taken tetanus before and what is the current status for the tetanus, whether the patient has any allergies before. We can examine the wound, see the location, size, depth, and most important to see the distal neurovascular status. We should assess the risk, whether this is a high risk wound or not. That we can see by seeing whether any contamination is there, any other foreign body is there, whether any deeper structure is involved which is very high risk for developing infection later. And you should always look for the red flags, like any tendon injury, nerve injury, or a neurovascular or a vascular injury distal to the wound or at the site of the injury. So this, I think most of the people sitting here will be knowing. There are 3 steps to the wound healing. First is the inflammatory phase, second is the proliferative, and the third is the remodeling phase. So what are the certain priorities in physical examination? So first priority as an emergency physician should be to look for the red flag signs. So these red flag signs are, you should assess the neurovascular status, because as an emergency physician, our job is to first identifying the limb-threatening injuries in the case of a wound. So if person is coming with a wound and you feel that there might be a limb-threatening injury, that means the wound is hurting or it is affecting the vascular status of the limb. So you should focus on that first and try to stabilize that and try to do the management for that. Further, if it is not a limb-threatening injury, we can move further with further examining, like looking at the location, size, depth and shape of the wound. We can test the neurological functions distally and systematically, and we should definitely explore for foreign bodies or any tender or joint involvement, because these becomes very high risk wounds, which might later go into infectious process. So how can we detect foreign body? So if it is a radio-opaque foreign body, we can do plain radiographs, but we have to make sure that we take 2 views, so understand the depth and the location of the wound. If a radiolucent body is there, now we have a very important bedside tool called POCUS, which we can use as a bedside ultrasound to find out these radiolucent bodies. 38% of the foreign bodies, if we see, are missed in the initial examination. So if you have high suspicion of it, you should look for it, because later it might lead into a highly infectious wound if it was not identified early. So suppose there is a patient who is having a foreign body in the hand. So what you can do? So you are suspecting a foreign body. You first of all do a clinical examination and try to find out where it can be. You take 2 views of that particular limb. If it is metallic object, X-ray will be positive for it. So based on the depth, you can ask for an exploration or an OT exploration for the foreign body. If it is a non-metallic foreign body, it won't be there in X-ray. So you'll have to do a bedside ultrasound and identify the depth of the foreign body. Again, if it is ultrasound positive, you can do either a bedside localization or you can ask for an intraoperative localization based on the depth of the foreign body. Still, if after ultrasound and X-ray, still clinically if you're suspecting that there might be a foreign body based on the mechanism, you should go further with higher imaging, like consider CT and MRI. CT for a metallic object, MRI for more of a radiolucent foreign body. So moving further, previously we used to know that A clean wound is something which happens within 6 hours. But the now literature tells that there's nothing like a 6-hour window for closing any wound. There's nothing like 6 hours for a clean wound. The new evidence-based reality tells most wounds are safe to close within 8 to 12 hours. Even the facial wounds can be closed up to 19 to 24 hours. And this decision is not only based on what time the wound was sustained, but it is more of a multifactorial decision. So you have to look at what is the prior comorbidities of the patient, what medications he is taking, whether he is immunosuppressed or not, whether he is high risk for developing infection or not. So it is a multifactorial decision, not just based on the timing of the sustaining of the injury. Moving forward, this is one of the steps which we neglect a lot. This is one of the steps where we come as the first responder. So we should know in and out of this step, which is wound irrigation. So first thing is, in wound irrigation, even the volume matters. So we should use at least 50 to 100 ml per centimeter of the laceration length. We can use either a normal saline or tap water because both are equally effective and these are cost effective. And also it will save a lot of resources for us in an emergency department. Antiseptics like iodine or chlorhexidine are no better than normal saline or tap water. And if we use it, that may impair healing of the wound also. And also, how you're cleaning or irrigating also matters because the pressure generated while doing the wound irrigation is also unique for the type of wound we are cleaning or irrigating. So there are two kind of irrigation system which we can use. For an Indian setting, this is more of a US setting thing. For an Indian setting, we can modify it. So we can use a 10 ml syringe with a 22 gauge needle to use low pressure, which will generate a pressure of around 13 psi. We can use a 50 ml syringe with a 19 gauge needle for generating a high pressure setting, which is around 35 psi. So what we do generally is putting IV bags and a bottle to it and do irrigation. But if we see that produces a very low pressure and it is very insufficient for a efficient wound irrigation. So suppose anybody would from the audience would like to answer this. So if there is a clean uncontaminated wound, what pressure system or what pressure we should use? Anybody? Okay, so correct. So it is a clean uncontaminated wound, so we can use a low pressure system which is 13 psi. Again, in an Indian settings, we can use a 10 ml syringe with a 22 gauge needle for this pressure. So what are the different closure methods? We can use sutures, we can use tissue adhesive, and we can use staples. These are some kind of suture materials. One is the absorbable suture material, which we generally use in a deeper layer when we are doing subcuticular or pediatric suturing and when we are suturing the oral mucosa. And these are some non-absorbable suture materials, which we use more for strength. One advice I'll give, monofilament are preferred for contaminated wounds because polyfilament suture materials are having high risk of causing infections later. Then suture size selection, this can be a brief review of that. For face, we need very fine sutures, so 5 or 6 sutures, and for the scalp, trunk and hands, we can use 3 to 4 size sutures. Suturing techniques can be also multiple types. They can be simple interrupted sutures, they can be vertical mattress sutures, subcuticular and running sutures. This can be further studied in the books. So now we'll move forward to the second part of the review, which is more about the mammalian bites. So suppose a 7-year-old boy presents with a dog bite to his right cheek, which was sustained 2 hours ago. The wound is 3 centimeter, it has clean edges, and dog is known family pet, which is fully vaccinated. So there are two questions to consider: whether we should close this wound or not, whether antibiotics are required or not, whether any particular prophylaxis is required or not. Anybody would like to answer? Yeah? Please stand up. Someone who was attempting. Prophylaxis of? But they're telling you he's fully vaccinated. Then also it is required. Anybody else? So if you have a proper documentation that the pet is fully vaccinated, ideally rabies vaccination is not required or the prophylaxis is not required. But then you need to get that proper vaccination, which is very difficult in an Indian setting to get. But now as the people are becoming more literate, they sometime if you ask them, they will definitely bring you the proper vaccination certificate. Okay? And whether we should close or not, close this wound or not? Yeah? Yeah, so ideally these wounds should not be closed up to 6 hours at least. Once we have given the immunoglobulin, then we can consider closing them. Yeah. No. If I'm telling in such case of wound where you're trying to give immunoglobulin, you should wait for immunoglobulin to be given, then only we should close it. Otherwise, we should leave it open. Because there are high chances of inoculation of the virus further if we close it. Okay. So this is one of the Indian data which is present in the Lancet. So there are 6 to 9 animal bites per 1,000 population per year, and most of them are mostly dogs. Out of which 89% of attacks which are happened by dogs, only infection rate is 3 to 20%. If we see cats, 8% of attacks are caused by cats, but the infection rate is 30 to 60%. So you should know when to give the antibiotic prophylaxis. So ideally, when a dog bite happens, you need not to cover with an antibiotics. But when a cat bite happens, definitely you need to give an antibiotic prophylaxis. And we should consider the high-risk patients like the pediatrics or the patients who are immunosuppressed. Definitely for them, we need antibiotic prophylaxis. So why there are more chances of infection in cat bites? Because they have more fang-like teeth which can create deep puncture wounds. The inoculum is delivered deep into the tissue. Plus the geometry or the anatomy of the teeth is such that the entry point seals rapidly. So it prevents any drainage of the bacterial inoculum. So this is the general microbiology which we see in the wounds. So for a dog wound, it is mostly Pasteurella, Streptococcus and Staphylococcus. For the cat, it is most of Pasteurella multilocida, which is most common, or it can be polymicrobial infection. For humans, it is Ichneella. So generally, the first choice for the antibiotic is amoxiclav. The prophylaxis we should give for 3 to 7 days. If you are suspecting an active infection, you can give it up to 10 days. So this is a general dictum when to give prophylactic antibiotics. First is all the cat bites should receive prophylaxis. All the hand wounds should receive prophylaxis if there is hand wounds because of any mammal, including humans. All the immunocompromised patients, if you're suspecting that they are high risk for any infection, should get a prophylactic antibiotics and a deep puncture wound. Moving further to the tetanus decision. So there are we can divide the patients into 2 types. The one patient who has received 3 doses of vaccination and it is well documented that they have the immunoglobulin in them. Second patients are for which the status is not known and the doses are less than 3. So if it is a clean and minor wound, we give only the toxide for the people who don't know there is unknown status. If for all other wounds like the dirty wounds, or the wounds which are contaminated with dirt, feces, soil or saliva, or having avulsions, or wounds resulting from any missiles, crushing, burns or frostbite, we should definitely give the immunoglobulin too. The second, the people who have taken more than 3 doses, generally they do not require any immunization if they have taken within 10 years. But if it is a patient of an HIV or an immunosuppressed patient, they might require if they have taken less than 5 years ago. What about a human bite? So there is a patient, 13-year-old man with small laceration of the 3rd MCP joint of his right hand. This happened when he was fighting in a club. So do you think this requires an antibiotic prophylaxis? Anyone? Tell. Stand up and tell. Yeah. Does he require? Yeah, okay. So correct. Any mammalian bite which happens on the hand, especially human bite, definitely requires an antibiotic coverage. So the clenched fist injuries, these are very high red flag injuries because these are more serious type of human bite injury. They are very high risk of septic arthritis of the small joints of the hand and they should be explored sometimes. in extension flexion position, that whether the joint is involved or not. And this is one of the indication where we should consider an opinion from the orthopedic or hand surgery consultation, whichever is there in your department or in your system who looks after these injuries. Moving further to rabies risk assessment. So this is WHO criteria with modification from the Indian side. So first of all, we should categorize the risk. So there are 3 categories. First is there is no exposure. That means there was touching or feeding. There was just a lick on the intake skin and there was no bite or scratch. Category 2 is minor exposure, where there is nibbling of the uncovered skin. There are superficial scratches or abrasions without bleeding. And the third category is the severe exposure, where there is bite and scratch with bleeding, with lick on broken skin and saliva or mucosa is involved. Or any bet exposure is also category 3. Second, we should risk assessment the wound. So how to manage the wound first? So we should have a wash with soap plus running water for more than 15 minutes. We should apply povidone iodine or virucidal agent if present, and avoid any kind of primary suturing. If essential, do after giving rabies immunoglobulin in category 3. So if it is a wound which is affecting the, it's in the part where it requires suturing, we do it after giving the rabies immunoglobulin. Then this is for whom what to give. So if it is a previously unvaccinated patient, category 1, no treatment is required. Category 2, you can do either the IM prophylaxis or the ID prophylaxis. And category 3, you have to do start immediately the vaccine. For patients who are previously unvaccinated about the immunoglobulin, you need to give only in the category 3. For previously vaccinated, you can give up to 2 doses of reprophylaxis in the case of category 2 and category 3. And the patient who are previously vaccinated generally doesn't require any treatment. Moving further. So also one of the important decision in emergency department after wound management is when to call for a consultation, when to call for a proper surgeon consultation. So important points in this is, if the patient is having a neurovascular compromise, always involve the next specialty which sees in your department. Also, if there is a tendon or muscle injury which is affecting the working of the patient, which is very severe for the patient, for that it has to be involved. If there is a facial wound which is crossing any cosmetic landmarks like the vermilion border or an eyelid margin, you should involve the concerned department. And if it is a complex hand injury or some clenched fist injury, you should always involve the concerned department. Post repair, you can give these instructions. You have to keep the wound clean and dry for 24 hours. They are safe to shower or wash it after 12 hours post closure. They have to elevate injured extremity in case there are high chances of developing swelling, and they have to return immediately if they develop any signs of infections. Signs of infections include any redness, increasing pain or tenderness, any purulent discharge or foul odor, or an elevated temperature. So this is one of the approach you can take home. So initially we have to consider whether the wound has high risk factors. So whether it is infected, it is contaminated, or not on head or neck. So you choose closure method based on that. Okay. If it is yes, if it is not there, you look for the second category, that whether there is a fracture or a foreign body. If it is there, obtain radiograph or ultrasound or imaging and manage otherwise. If it is not there, you look for any following factors like any neurovascular injury is there, any joint involvement is there, any tendon or muscle injury is there, or any amputation has been done, or any amputation has happened, or it is related to a blast or high pressure injury. If it is there, you give the primary management and involve the concerned department. If it is not there, you can proceed with the primary closure in the emergency department and give them proper advice and counseling, which I already discussed, and tell them what are the red flag signs for them to come and revisit the ED. Okay? So this is the basic algorithm you can follow. Common pitfalls are, you always follow this, try to not miss any foreign bodies. For the patient having high risk, give antibiotic prophylaxis. So any questions, you can ask me now. This is the 5 minutes, we'll start for any interactions.
So first patient, what did you do? That patient who had a hand laceration.
So patient who had a hand, Can I? Can you put the
So,
slides?
anybody, what will you do in this?
I'll just show the question again to everyone. Slides.
Quick. It will take long. So it was a hand laceration that
Yeah.
guy had some.
So there is a hand laceration. It is of around 5 centimeter. It was it occurred 4 hours ago.
Okay.
Patient is diabetic and on aspirin.
Yeah. So what did you manage this case?
Yeah. So this patient had a contamination with dirt. So it is very important to give high pressure irrigation.
Okay.
Second thing, patient had an injury with a broken glass. So it was
Okay.
very important to search for a foreign body.
Mhm.
And patient is diabetic. So it was very important to give an antibiotic prophylaxis.
Okay. So how will you search for the foreign body? How will you search for the foreign body?
So for searching for foreign body, we have to consider based on the history of the patient. If you are suspecting a radiolucent or a radio-opaque foreign body, if it is a radio-opaque foreign body, we go ahead with X-rays of the two views of the same site. If it is a lucent foreign body, we go ahead with the ultrasound, which we can use
So
bedside
how
purpose.
do you do the ultrasound in the hand?
We can ultrasound of the hand. We can use the straight the lung probe or the low frequency probe, the high frequency probe, and we can use the preset of musculoskeletal tissue, and use the superficial settings, preset settings, and look for the foreign body, which will appear as a high density structure inside the soft tissue.
Yeah. Sometimes you can put it in water.
Water bath. We can also do the water bath ultrasound.
Yeah. Okay. And the other thing is, the most important thing is sometimes you might see a glass piece, then you remove that glass piece and then get the X-ray. Okay. So
Okay.
that you can see more foreign bodies.
Okay.
And then another thing what I would do is, after you get the X-ray, you need to numb this area, and then sometimes there will be blood, you will not be able to see the foreign body. Make sure you control the bleeding and go and see the base of the wound. Okay. It's very, very important, because otherwise you will miss the foreign body. See, you said 38% are missed. And that is because people don't see it.
Correct.
You need to make sure that you have good lighting and you expose and make sure it's the bloodless thing, so that you can do. And sometimes I even use a forceps and all these things to find out whether there is any foreign body, or whether I feel anything. So it's very tricky, it's not easy.
Correct.
And if you suture it and later on the patient goes somewhere else, they can sue you.
Correct.
And infection, and especially hand, hand infection is a bad thing. Okay. So it's very, very important that you are very, very these things are not like you have to do it in every wound.
Correct.
Make sure that whether there is a foreign body, you make sure that you document that you explode up to the base and there is nothing. And you said another thing, the 3 centimeter laceration in the cheek, and why you said you are not going to close.
Yes, sir.
Why you don't want to close?
No, if it is a vaccinated
This is
child,
vaccinated.
then I will definitely close.
Yeah. So you need to close, because if there is a 3 centimeter in the face, especially in a child, they will have a bad scar if you don't close. Okay. And the chance of infection in the face is much less. It's like 5%, 10%. And if you irrigate and put treat with betadine and all those things, I have never seen any infection in the face due to the thing. So human bite is the most high risk of infection. So that is very important.
So I wanted to highlight this point that in most of the Indian settings, they will tell that the pet is fully vaccinated. But when you ask for a documentation of that, they won't be able to present
We
it.
don't
So
need the
it's
documentation. We don't need documentation. I don't know. There, due to dog bite, the rabies is not been reported for 60 years in Washington State.
Okay,
so
sir.
we.
Okay, sir.
And even you can clean it and then later on find out whether they have the vaccination certificate. If not, they can
They
start
can
the
get
vaccination.
vaccination. Okay, thank you.
Thank you, Dr. Arihant, for that practical and insightful presentation. Your approach reminds us that meticulous evaluation and thoughtful management are key to achieving the best outcomes in wound care. Now we turn to a presentation that often creates urgency and uncertainty in the emergency department. When a patient suddenly collapses, clinicians must rapidly determine whether the cause is benign or potentially life-threatening, often with limited information. Helping us navigate this clinical challenge when the patient drops, a systematic approach to syncope in the emergency department. Please welcome Dr. Srijit J, MD Emergency Medicine, Senior Resident at the Department of ED, Amala Institute of Medical Sciences, Thrissur.
Good afternoon, everyone. So, just as I had the introduction, this is actually a tricky topic. And the importance of this topic in the BREM session is actually... The importance of this topic in the BREM session is actually this question, approach to syncope, has been asked multiple times in theory examination, especially the board final examination. In 2019, it was in the DNB exam, 2022 and 25, this was part of a DNB exam, and in multiple board exam, this question was asked. So from the BREM point of view, why this topic is important is, it has been asked multiple times, yes, but the approach to syncope, are we doing it right all the time, or is there something that needs to change? Are we having the correct concept when we are approaching syncope? So let's try to break it down. This scenario, a well-appearing patient walks in ER saying, I fainted for a few seconds. Yes, it is not an uncommon scenario for our ED physicians, right? We have seen this case. We have seen it multiple times. So when such a patient walks in, what is the thought that comes to your mind? Is it about making a diagnosis? Somebody is nodding their head, yes. Or is it about looking for the danger signs? Or what is the thought that comes to your mind when you encounter this patient? Anyone? Is he in danger? See, let's move forward. So is our job as an ED physician, are we trying to find a diagnosis of why the syncope happened? Just before I came into this session, I was having a conversation with my one of the friend outside, and he was asking me what my topic is. Then I told it is syncope, and he was thinking, and syncope could have n number of causes. And how are you going to cover it in 20 minutes? So I wanted to tell that it is not possible to make a complete diagnosis. I'm stressing on the point, the complete diagnosis in a syncope patient. What we can actually do in an ER is we can identify if it was a true syncope or not. The second thing is there a serious cause that can kill them soon? Or the third question, does that patient actually require admission, or does he require monitoring? So the first step, confirm it is actually a syncope. Do we have a definition of syncope? Someone in 2019, they actually published data where they tried to define what true syncope is, and true syncope is transient loss of consciousness due to cerebral hypoperfusion, rapid and spontaneous recovery with no persistent neurological deficit afterwards. So what are the causes of syncope? Just as my friend has told, what are the causes of syncope that might be there? There are n number of causes, yes, definitely. So let's see some of the most common causes. The cardiac one, the arrhythmias, structural heart diseases, pulmonary embolism, MI, or even ischemia. The reflex, which is the naturally mediated. The vasovagal syncope, situational, even when a person is coughing, micturition, defecation, or carotid sinus hypersensitivity. Or could it be orthostatic? Yes, possible. We have seen those patients in ER. Volume depletion, dehydration, autonomic failure, medication induced. And what are the other mimics of syncope? Yes, it could. Hypoglycemia, seizure, stroke, and TIA could also be the other mimic cause. In this class, I'm not trying to tell you what the causes are. And even if you check the literature, there are very less discussed literature in the syncopation. One of the faculties who was taking class in the previous session, he actually published an article recently where he discussed extensively about the syncope sessions. And one of the main concept which we have to do is we have to exclude the mimics of what is actually causing syncope. Could it be a seizure? So how does the seizure patient present? There will be post-ictal confusion, there will be incontinence, a history of tonic-clonic activity from the attenders. And what are the other transient loss of consciousness mimics? Hypoglycemia, intoxication, and psychogenic pseudosyncope. We even get to see all these patients, yes? So the dictum is that if there is no syncope story, then there is no syncope pathway. We have to look for other causes. So when we're trying to treat, where do we begin? Is there any alternate pathway? We stick to the basics all the time. We proceed by airway, breathing, circulation. We attach the patient to the monitor. We proceed by doing a 12-lead ECG. We do the bedside glucose test, IV access if the patient is ill appearing. And then after a primary survey, we try to identify what are the red flag signs in a patient of syncope. So what are the red flag signs? The patient might be in hypotension or shock. The patient might be complaining of chest pain, dyspnea, or hypoxia. The patient might be in altered sensorium. There will be a focal neurological deficit. Major trauma from fall resulting in a syncope. Yes, danger sign from the history. Any signs of anemia or any ongoing bleed or anything. So if you are seeing the red flag signs, don't be like this. So can a good history supplement your investigation? No. So what are the things you can ask from the history? What was the circumstance of syncope? How did the syncope actually happen? Was it during exertion? What if it was during exertion? It could mean an underlying structural heart disease, arrhythmia or something. Was it during supine? Because cardiac arrhythmia, most commonly the syncope happens while the patient is in supine position. Was it sudden onset without any warning signs? Was it after prolonged standing? And also take a small history on the medical history, like what if the patient was having a structural heart disease, prior MI, heart failure, cardiomyopathy, known arrhythmias, or a risk for pulmonary embolism. And what was the prodromal symptom? Just before the patient collapsed, what was the prodromal symptoms which was there for the patient? Like was there palpitation, complaints of palpitation before the syncope episode? Was there chest pain? Was there dyspnea? Or was it headache or any neurological symptoms that led to the syncope? Was there nausea, sweating, or warmth of complaints which could indicate a vasovagal syncope in this patient? Was the patient actually on any medication? This is one commonly we get. The patient came to the OPD to revise the antihypertensive medication and then suddenly collapsed and was brought to the ER. So what are the medications? Antihypertensive, diuretics, antiarrhythmics, QT prolonging drugs. Was there any associated trauma for the patient? Was there any history of sudden cardiac arrest that might put the patient in danger? And from the patient, from the attenders who witnessed the event, we can also get the history, like was there any tonic-clonic movement, was there post-ictal confusion, tongue biting, which all could indicate that it was not actually a syncope, it was a seizure episode. So what are the physical examination signs which we look for? From the vitals and from the primary survey, yes, we look for the hypotension, tachycardia, bradycardia, fever, and we check the BP. We keep a differential diagnosis as orthostatic hypotension. We examine the patient cardiovascular system and look for murmurs or any signs of heart failure and any irregular pulse, especially the arrhythmias we have to rule out. And the neurological examination, which will focus on the focal deficit and altered consciousness and signs of any pulmonary embolism. So let's take up this case. A 55-year-old man is brought to the emergency department after sudden loss of consciousness while walking. He regained consciousness spontaneously within a minute. And the history, there was no seizure activity as given by the bystander, no tongue bite, no incontinence, and the vitals are within normal limits. And examination, normal neurological examination, no focal deficit, and past history, hypertension or medication. And now the question is, what is the next best one single investigation if you had to choose? What would be the next best single investigation? Anyone? ECG. So why ECG? Because ECG is mentioned as the universal syncope test. Why? Because if a patient is coming to you in syncope and you have an ECG, what are the things you look for in an ECG? In a patient with syncope. Obviously, you have to look for the signs of ischemia. Obvious signs will be there. Signs of an arrhythmia, which you have to pick up. And there are very small things which we tend to miss, but has to be kept in mind when a patient with syncope presented to you and you took an ECG. So to understand that, we have this wobbler mnemonic. Wobbler, W stands for the WPW syndrome. O stands for the obstructed AV pathway, that is any heart blocks. B stands for the bifascicular block. B for Brugada syndrome. L is for the left ventricular hypertrophy, which might indicate there is an underlying aortic stenosis or an hypertrophic cardiomyopathy. Epsilon wave, which is seen in arrhythmogenic right ventricular. And R, which is for any repolarization abnormality, which might be a long QT or short QT. This is a QR code which you can scan and see for all the ECGs, because for the time limitation is there, I have not included the ECGs as part of this, but you can scan this and check all these minor killer ECGs. So, what if the ECG is normal? Will we discharge the patient? I will again rephrase the question. What if the ECG is abnormal? If the ECG is abnormal, it is fine. We have to admit the patient, we have to get a consultation done, we have to monitor the patient. What if the ECG is normal? Can we discharge the patient? A repeat ECG. Okay, fine. Let's move forward. So when are we supposed to do the lab investigation, or when are we supposed to get an NCCT head done for the patient? Lab investigation are supposed to be done when we are actually suspecting something, like suppose if we are suspecting bleeding, which might be the cause, or if we are suspecting anemia as a cause of syncope, then get an HB done. If there was history of vomiting, diuresis, or if we are actually concerned about the QT interval, check for the electrolytes. If there was history of dehydration, prolonged standing, get a creatinine level done. And sometimes patient who is a pregnant woman might present as initially as syncope. So when you are in doubt, do the beta HCG. And if you are suspecting acute coronary syndrome, yes, we can get a tropoid done. So the lab investigation is mostly related to what you are suspecting. And when do we go for the imaging? When do we decide we need an imaging? If there is any focal deficit, if there was history of any head trauma, if the symptoms of severe headache is there, patient is complaining of severe headache, and the patient was already on anticoagulants, yes, we can go for a NCCT head. And what about pulmonary embolism? We have to do the pulmonary angiography. So this is all, I'm almost halfway through my lecture, and till now I've not talked about the scores. So everybody, I know most of you would be waiting when I'm going to talk about the scores. So when are we supposed to score the patient as low risk, high risk, intermediate risk? When are we supposed to do that? Okay, I'll try to answer that question. First category of patient is where the cause is identified, which is the cause is identified and the patient is likely benign. Benign in the sense which is a classical vasovagal trigger which was along with the prodrome of symptoms, and there was clear orthostatic hypotension, that is dehydration or medication with improvement after treatment, no high risk features, normal examination, normal ECG. Will we risk stratify these patients? No, these patients don't actually need the syncope scores. We have to treat the cause and discharge them with the precautions. Yes. Coming to the next category, the high risk patients where the red flag signs are actually present. Any structural heart disease, exertional syncope, the patient is in supine position, palpitations, complaints of palpitations, instantaneous collapse, persistent hypotension, and any ECG positive findings. So these are the high risk category. In the earlier slide, I talked about the low risk category where we can easily discharge the patient. High risk category where we have to admit the patient and monitor. So there is a category of patient who is coming in between this. That is the category C. There is indeterminate cause after the ED evaluation. So after ED history, examination, vitals and ECG, there is no obvious diagnosis and there is no clear high risk features also in that patient, but you still as an ED physician feel the uncertainty. Yes, whether we have to admit the patient or whether we have to discharge the patient. In those patients, we can actually use the scoring system. The score, so the use of scores are for uncertainty, no obvious, if there is any anything that is not explaining, not fitting to your usual syncope pathway, do not let them override your clinical red flags. So the first score which I want to tell is the Canadian Syncope Risk Score, CSRS. Let's break down the categories. First is a clinical evaluation. So what are the parameters? Predisposition to vasovagal symptoms, which is actually given -1, and history of any heart disease, any systolic pressure reading less than 90 or more than 80, and what are the lab investigation? Tropi levels, abnormal QRS less than -30 or more than 100, the QRS duration, and the corrected QT interval. And one important thing the Canadian syncope score actually calculates is the impression that an ED physician makes. If it is a vasovagal syncope, it is given -2, or if it is a cardiac syncope, it is given 2. So the total scores actually varies from -3 to 11. If it is more than 5, it is a high risk patient. So what is the specialty of this Canadian syncope score? It is the most validated ED score, which is actually predicting the 30-day serious adverse effects, and it actually incorporates the ED physician's impression, and the predictive performance is almost 0.91. Coming to another score, which is the San Francisco syncope rule, this is the score which we might have heard about more, or which we tend to use more because the parameters are actually very less. So there is a mnemonic for that, the chest parameters: congestive heart failure history, the hematocrit less than 30, ECG abnormalities, shortness of breath history, or the systolic BP less than 90. So what is the issue with the San Francisco score? Even though the sensitivity is 86 to 97%, the specificity is only 48 to 49%. So what does it mean? We tend to over-admit the patients if we are looking for this San Francisco syncope rule. There is another score known as the Rose score, where we use the blood BNP levels, heart rate, rectal examination for fecal occult blood, anemia, chest pain, ECG changes, and saturation levels are calculated. But this is not used these days in an emergency. This is just a comparison of all the syncope scores, and which from an ED point of view, we usually use the Canadian syncope rule. So in a patient who is actually in gray zone, which is not having a benign cause, but not having a danger zone, not in the danger zone, who is actually in the gray zone. And are we supposed to discharge him? Yes. When the patient is stable in emergency, the benign mechanism is likely, no high risk features from the history, and ECG is reassuring, that is the wobbler which we discussed is negative, no dangerous alternate diagnosis is suspected, and discharge is safe logistically. So these are some of the recent advances which we have. In a new concept of syncope observation units is coming up in foreign countries, where the ED people are admitting the patients of syncope, and there is a protocol for monitoring the patients with ECG, orthostatic testing, and early cardiology follow-up. And now incorporating all the clinical signs, lab investigation, AI systems have developed, where we can risk stratify the patients in syncope as high, moderate, and low risk patients. And there are smart wearable devices which has been coming up in the market, where we can continuously monitor the patient who has at high risk for heart rate and systolic blood pressure. And there is an ambulatory blood pressure monitoring system also available for patients suspected of vasovagal syncope. So I would like to finish this session by stating that syncope is actually very common, but the dangerous signs are not. You have to actually find them from a good clinical history and with a good ECG analysis. Thank you.
Any questions? Yeah.
Talk to him actually. The previous speaker told. Can I talk?
Yeah.
About the vaccination of the, not to you actually, the animal vaccination, but even the other vaccination that is used for human beings, we have doubts regarding the quality of the vaccine. There were newses, right? So I'm working in the government sector, sir. We don't ask whether the dog was vaccinated, we just give.
Okay, that's fine. That's fine.
Actually, our previous speaker, he has written a blog on syncope, and some of the points from this slide has been taken from his blog, which is actually recently published, and which is a very good article to read, and yes, thank
Yeah.
you.
So, most important thing is whenever you have a patient with syncope, history is very important. By history, I will have a pretty good idea whether, is, because patient who is like urinating and having syncope are straining at the stool in a toilet, and elderly people, and you will get a pretty good idea, what it is. Or a young person standing long time having like sensation, nausea, and suddenly passing out, or they are like suddenly stressed out and they are passing out. So history is very important. Okay. Then the EKG. Whenever you read the EKG in a syncope patient, make sure whether there is any blocks, right bundle branch block, and things like that. And you have to say normal sinus rhythm. I always write in a syncope patient normal QT interval, no evidence of Brugada syndrome, no evidence of WPW syndrome, you know, is very important, because sometimes I had a patient once, this EKG didn't show delta wave, the previous EKG showed a delta wave. So, and this guy passed out, and he had a malignant arrhythmias, like fast AFib, and he passed out. So, those things are very important, why they are passing out. Most of the time it is benign, but we have to always think about like ectopic pregnancy, they will present with syncope, So you have to say whether they have any abdominal pain and pregnancy test and things like that. And same thing, PE, suddenly they will come with syncope, and they are like, they're one patient I know, she was not like complaining of that much. She passed out and she was a little bit hyperventilating, little bit, So the nurses were saying she's anxious and she passed out and things like that. But her SATs were around 93%. I was thinking, why if somebody is hyperventilating, the SAT should be 100%. So we send the D-dimer, just to see, because nothing else. EKG showed some like sinus tach, like 110. And she had a P, massive bilateral P. So you have to think what all can be there, and you have to do a good clinical exam, see whether they have aortic stenosis. You hear a murmur of hypertrophic aortic, HOCM, and things like that. Somebody is playing basketball and so you have to really history, physical examination, look at the EKG, then any change of the medications. I had a patient whose Lasix and spironolactone dose was increased, and he had a syncope and then that guy had a like orthostatic hypotension. So you have to measure the BP. So it's all, it's a good, thorough history, physical examination, and thinking of what can cause. If I discharge this guy, what I am missing, If you rule out GI bleed, and sometimes they might have black stools for a few days and they might have, passed out. And so you have to, look at that and all these things. Good.
Thank you.
I'd like to emphasize one point. How will you, so how should we consider pre-syncope also in this situation? Like whether we should pre-syncope and syncope?
Pre-syncope is equal to syncope. That's what I evaluate.
Thank you, Dr. Srijit, for that clear and structured discussion. Your systematic approach provides valuable guidance for evaluating syncope with confidence in the emergency setting. Our next session focuses on one of the most dramatic emergencies physicians encounter: upper GI bleeding. From the subtle appearance of coffee ground vomitus to a rapidly deteriorating patient requiring urgent resuscitation, early recognition and appropriate risk stratification are crucial. Guiding us through from coffee ground to code red, risk stratification and emergency department management of upper GI bleed. Please welcome Dr. B.L. Manish Kumar, MD, DNB, Senior Resident at AIIMS, New Delhi.
Good afternoon, everyone. Hi, sir. Good afternoon. Good morning, sorry. Good morning. What's your name? I thought you had syncope. Good morning. Okay. Our topic is, by the way, I'm Dr. Manish. I'm Senior Resident at AIIMS. And my topic is coffee ground to code red. You understood the topic, right? Upper GI bleed. So we will start with a case scenario. How many of you are from Kerala here? So many people. You are from Delhi, right? Okay. So it was one day after Onam and Kerala broke all the records and Kerala has collected 800 crores. You know what I'm talking, right? Kerala has collected 800 crores and you are working in ED. Time is 12:15 a.m. Dark night, and 38 years male Jijo, who has contributed so much in that 800 crores, has come to ED. He is an alcoholic for 15 years, and his wife rushed him into ED, and she says that Jijo had 2 episodes of coffee color vomitus and 1 episode of dark stool. Right. And while coming to hospital, he had 1 more bout of vomiting, but this time it is red in color. So, what are you thinking about? One of you can answer. What is the probable diagnosis in this? Variceal bleed. Excellent. I thought you will tell upper GI bleed, but you directly went into the answer. It is variceal bleed because I gave history of alcoholism. But it can be gastritis also. Right. So let us keep it to upper GI bleed. Coming to the upper GI bleed incidence, around 50 to 150 people out of 1 lakh will be having this upper GI bleed. This is Indian data. I'm not telling worldwide data because according to worldwide data, variceal bleed is very less. But if you come to Indian data, it is lot more than peptic ulcer. Right. And elderly are more affected because of their comorbid illness and mortality. What is the most common cause of death in upper GI bleed? Hemorrhagic shock? No, it is septic shock. Right. So we will be discussing only updates of upper GI bleed because in 20 minutes I cannot cover upper GI bleed as a theory. So we will be talking about all the articles which have published after 2023 only. Right. So 68% of the times these patients will be presenting with hematemesis and 54% of the times with melena. And if the patient is having bright red blood, that suggests that patient is having recent or active bleed. Right. So this patient has presented to you with coffee ground color. Why is it coffee ground color? Dr. Mahadev, why is it coffee ground? So exposure to gastric acid is the thing, right? So these are the types of bleeding. If you see here, everyone is able to read the slides, right? Or else I will read it out for you. Types of bleeding is hematemesis, where fresh blood will be coming out, and upper GI bleed. This suggests that patient is having upper GI bleed. Coffee ground color because of exposure to gastric acid. Melena because patient is having, this has to transit through the lower GI bleed, lower GI also. During that time, it becomes black. Then hematochezia. Hematochezia is a lower GI symptom, they say. But 14% of the times, if the patient is having very brisk bleeding, so blood doesn't have enough time to transit all through, blood will transit very fast. So hematochezia also can present in UGI bleed patients, right? What is occult GI bleed? You would have read in parasitology. Stool mein there will be some blood cells. That is occult bleed, where patients will not have any bleeding per se, right? Then obscure bleed. This is a new term. What is obscure bleed? Source cannot be found out. As Asta was telling that source cannot be found out. Patient is having hematemesis. You are seeing hematemesis, but you cannot find out a source. That is obscure bleed. Usually the cause will be somewhere in small intestine. For that you have to do capsule endoscopy, right? So patient has arrived to triage. So these are the vitals you are seeing, and patient is pale and anxious. These are the vitals. Everyone is seeing the vitals, right? Dr. Arihant, what are the red flags here? Don't tell your girlfriend's name. What is the red flag here? Yeah. Anxious, tachycardia, anxious, syncope, right? So coming to the red flags are syncope, orthostatic hypotension, tachycardia, hypotension, angina, type 2 angina can be there, type 2 MI, and weakness, confusion, unexplained shock. These are the red flag signs where you have to identify these patients and shift them to red area. Coming to the tachycardia, young patients may not have as expected tachycardia, and their BP drop also will take later stages, right? And in older patients who are having chronic hypertension, BP should not be the only criteria, because their BP can be baseline 160 coming to 120. And most of these patients will be on propranolol. CLD patients will be on propranolol for portal hypertension. So tachycardia might not be there, right? Now, Jijo's wife tells that patient is taking alcohol from 15 years. What is the other history you want to ask? Comorbid illness, basically comorbidities. You want to see if the patient is known CLD, CKD, CAD, or prior UGA bleed, right? And if the patient underwent aortic grafting, think of aortoenteric fistula, right? And if is the patient using NSAIDs very frequently, aspirin, antiplatelets, anticoagulants, right? Coming to the etiologies of UGA bleed, as Saurus told us, it is acute variceal bleed. Acute variceal bleed contributes to somewhere around 50%. Esophageal varices, gastric varices, gastropathies gave, right? Okay. Next is non-variceal causes. This is Indian data. If you have gone through your MBBS books, it will be written like 80% of the times it is non-variceal, 20% of the times it is variceal. This is published in Ames Rishikesh. They found out that variceal bleed is more common in Indian settings. Non-variceal, it is 46.4%. Out of that, peptic ulcer, gastritis, and duodenal ulcers are common. Okay. Coming to the new definitions. What is acute variceal bleed? When do you say it is acute? Sir, when you say it is acute variceal bleed, there is the concept called T0. T0 is the time when the patient had first bout of hematemesis. Suppose if the patient had first bout of hematemesis, that is not the time, right? Okay. At 3 o'clock, that will be the T0. And 48 hours after the T0 is acute. Within that 48 hours, how many times he had bleed, that will be considered as same episode. So acute variceal bleed is T0 to 48 hours. Coming to the recent bleed. Recent bleed is within 6 weeks if he has bleed after index bleed. So patient had bleeding today. After this 6 weeks, whenever he has bleed, that will be called recent bleed, right? What is active bleed? Active bleed is an endoscopic term. When you do endoscopy and you are seeing there is some oozing, there is active bleed or spurting, that is called active bleed. We have learned two endoscopic terms, that is obscure bleed and active bleed, right? Then you have seen the vitals of the patient in triage and you are examining GIJO, and you found patient is having vomitus which is red in color, or it can be coffee ground. Rectal examination can be done where you can see bright red blood if it is hematochezia or melanotic stools, right? So, and if you get enough time, you can examine remaining parts also, right? You can find spider angiomas, palmar erythema, everything which is suggestive of CLD. If you are thinking of CLD features are there and patient is having coffee ground vomitus, you should be thinking of CLD, portal hypertension, acute variceal bleeding. So while you are doing this physical examination, patient suddenly had a massive bout of hematemesis in triage. So what are you going to do? What is your next priority? So, airway, excellent. This takes us to the next concept, the vomiting airway, right? So you have shifted the patient to red area and Jijo is continuously vomiting. There are three options available for you. One is traditional approach, where you will be doing suctioning intermittently and doing laryngoscopy, which is very difficult. Then second thing is salad technique. What is salad technique? So everyone is doing routinely salad technique. I will show you a video of salad technique. And third one is, how many esophageal intubations have you done till now? Many would have done, but we are done without intention, right? Here we are doing with intention, intentional esophageal intubation, right? Why are we doing intentionally esophageal intubation? We are basically diverting the vomiters to not reach to the lungs. This is intentional esophageal intubation, where you will be blindly doing, without seeing the cords, you will just lift the, just do the laryngoscopy and put the tube and inflate it. You will confirm if it is in esophagus, so that you are diverting the blood. This is intentional esophageal intubation. Coming to the next technique called salad, right? And here I gave a caption, prepare to fail, but not fail to prepare. When you are dealing with UGA bleed airway, prepare to fail, but not fail to prepare, right? Suction assisted laryngoscopy and airway decontamination. In salad technique, we are using something called Ducantos catheter, which is a rigid suction. Even if you are not having Ducantos catheter, you can use it with a wide bore catheter, like Yankur can be used, right? So you are going to hold the Yankur, and simultaneously you are going to hold the laryngoscopy, and then you are going to, your catheter should be in front of laryngoscopy, so that whatever blood is coming, it is going to suck it. And with laryngoscopy, you are going to have a clear view. So continuous suction is going on, and you are having a proper glottic visualization. This is salad technique. There is something called salad park technique, where you will park the catheter in left side of the oral cavity. You will take the catheter, you will park it in the left side of the oral cavity, that will be continuously sucking out, and you will have a proper glottic visualization. This is salad park technique. Here you can see one of my JR is doing salad technique. I think I'm running out of time. Here you are able to see the glottic structures, and below is the catheter where he is going to place, right? So he is going to keep the catheter there only. He has sucked the blood. Entire blood is cleared now, and there you can see the glottis. So suction catheter is held there on the left side of the mouth, and here he is doing VL. There is continuous suction going on, and he is intubating. So he is getting a proper view. You can see some amount of blood which is being sucked continuously, and he is passing the bougie there. This is salad park technique. This is done by one of our JR, Dr. Prajwal. Okay. And coming to RSI modifications in UGI bleed. This is very frequent thing which frequently we will be facing challenges. I think we should discuss here. So prepare for contamination, full PPI, double suction, better to use video laryngoscopy, and then decompression of gastric contents. If you have enough time, put NG tube. If you are not having time, then you can directly proceed. And prokinetics can be given if you are having time. Then head up technique, 45 degrees head up, and preoxinate without bagging. If you bag, more vomiters will come. So better not to preoxinate with bagging, right? Next modification is induction agent is ketamine. This has been studied extensively. There is a meta-analysis on which induction agent to use, and they found out that ketamine has slightly better compared to others, but in a reduced dose because patient is in hypotension. Coming to paralysis, succinylcholine if you give, that will relax the lower esophageal sphincter and more risk of aspiration. So it's better to give rocuronium. Then, if you are expecting vomiting, Trendelenburg position or 45 degrees head end elevation. And after that, patient will be having aspiration, so give antibiotics if you are suspecting any chemical pneumonitis, right? This is one trial where they have now airway secured, right? So we can focus on what is bleeding. So they have conducted a study where they have used TEG, thromboelastogram, instead of coagulation profile. They thought initially their hypothesis is TEG worked excellently for trauma. TEG works excellently for trauma. So they have conducted a similar study for GI bleeds also, whether TEG will improve it, but TEG actually did not improve. TEG actually, patient who underwent TEG, thromboelastogram, had more requirement of blood products, higher mechanical ventilation, no mortality improvement. So you can just go ahead with your CBC, coagulation profile, lactates cross match. That's it. So if lactates are rising, that tells patient is having more mortality. You need not go with TEG. Okay. NG tube. Should NG tube be placed? European Society doesn't recommend NG tube usage, but if NG tube if blood is coming, that clearly tells that patient is having, there is high suspicion that patient is having UGA bleed. But if it is not having, if there is no aspirate, 15% of the times, pyloric spasm can be there because of blood, duodenal bleed, or intermittent bleeding. So that doesn't rule out. But I think we can put NG tube. I usually put so that we get a better visualization during endoscopy. Coming to transfusion strategy, restrictive one is better. If patient is having less than 7 grams, it's better to transfuse. Less than 8 grams for comorbid patients. Liberal transfusion is associated with more mortality and bleeding, because more the blood you give, more portal hypertension and more rebleeding. That was the concept, right? Coming to massive hemorrhage protocol. Should we activate massive hemorrhage protocol for acute variceal bleeding? Massive hemorrhage protocol has been studied excellently in trauma, and they found that MHP is life-saving. But in acute variceal bleeding, it is restricted only to peri-arrest and exsanguinating hemorrhages. And MHP is even associated with more mortality, higher failure, and great blood product use. So MHP is also not useful. Only if peri-arrest or exsanguinating hemorrhage, it's better to use. Coming to platelets, most of your patients will be on dual antiplatelets. They will be having CAD, so they will be on aspirin and clopidogrel. So in these cases, even if the patient is going to endoscopy, you just stop clopidogrel. Let the aspirin continue. Aspirin is life-saving, and that too it is low dose. So continue the aspirin, stop the clopidogrel for 5 days. This is the concept. And American Association tells that if platelet count is more than 20,000, proceed with endoscopy. And biopsies, though, mostly I don't think we are doing in EDs. FFPs and PCC. Only in life-threatening bleeding, even if the patient is having INR of 10 or 9 or whatever it is, if patient is not having any life-threatening bleeding, don't reverse it. But if patient is having life-threatening bleeding, give PCC, prothrombin complex, not FFP. FFP has lot of volume and risk of TRALI also. So give PCC, if PCC is available. If it is not available, you can proceed with FFP. And for direct oral anticoagulants, there is a reversal agent which is called edaravimab, which is very costly. So you can go ahead with PCC in this case also. INR and endoscopy. I think my JRs regularly face lot of issues with this INR and endoscopy. Gastro SR will tell INR is elevated, I won't do endoscopy. And my JRs will have to request him that, will have to explain him that INR doesn't matter. So European Society tells that there is no INR cutoff to do endoscopy. If the patient is bleeding, he has to go to endoscopy. And American Association tells that INR less than 2.5 is very good to do urgent endoscopy. So Jijo is now stabilized. We have given blood. So what are the drugs we are going to give him? High dose pantoprazole infusion, octreotide or somatostatin or terlipressin, ceftriaxone to prevent for prophylaxis of SBP, erythromycin before endoscopy, or metoclopramide. I think this PPT will be shared where I have written the mechanism of action of every drug. Trinexa should not be given. This is from HALTIT trial because it is associated with more venous thromboembolism, right? And patient's wife is asking what is the prognosis now. Okay, my time is up. 2 minutes more, okay. So we have to tell it with the objective evidence. Pre-endoscopic scores may, one thing if you want to remember GBS. This is one score which is really, really good. It will predict pre-endoscopy intervention should be needed or patient can be discharged. If the score is less than 0 to 1, you can safely discharge the patient from ED. So GBS is one good score. If you want to read 2 scores, then you can read pre-endoscopy, Rockall score. Post-endoscopy scores, if you are having ED ICU, Rockall score, Forest score for peptic ulcer, and CSMPI. These scores you can go back and read. These are nothing new. AIM 65 score is for mortality. You just have to know where you have to use which one. Rockall score before endoscopy, GBS score for every patient, AIM score to predict mortality if the patient is lying in your ED for many days. What is the uses of endoscopy? It will decrease the, if you are doing endoscopy in ED, they found out that there is decreased in-hospital mortality rate, decreased length of stay, decreased cost, right? And timing of endoscopy, if it is done within 6 hours, it is called, this is for hemodynamically unstable patient. Just like our GIJO, this fits into urgent endoscopy, right? 6 to 12 hours is early, and then it is called delayed. We are having ED endoscopy room in AIMS. So whoever the patient whichever patient is unstable, we shift them to endoscopy and we'll be doing endoscopy in ED itself. This is our endoscopy equipment. Mostly it will be done by gastric SRs. So right now we are started doing. And coming to endoscopy, endoscopic therapies are two, variceal ligation and sclerotherapy. This is the recent trial where they found that endoscopy along with vasopressins like vasopressin and NORAD tend to decrease the portal pressure and drug requirement, right? So coming to the disposition, okay. Coming to the disposition, this patient requires ICU because patient had significant hemodynamical instability and patient required vasoactive agents and intubation, right? All the patients who are admitted in ED should undergo endoscopy, then only be discharged. If the GBS score is low, patient can be sent home. Thank you. There were a lot of updates. I could not cover most of them, but you can contact me anytime.
Any questions?
I understand in India resources are one thing which is limiting. Endoscopy is not available in many centers. So as you asked, Senstagen tube. Senstagen tube can be used up to 24 hours and it doesn't require much of expertise also. And there is one more tube called Minnesota tube, and sir might be knowing because in US many pre-hospital workers, even paramedics are doing that. You can use it for 24 hours and by then you can refer them to any expert, any experts.
But in US, variceal bleed is not that common when compared to the peptic ulcer bleeding and all those things. So, and another thing is, what if the guy is like 70 systolic blood pressure and having variceal bleed and is vomiting?
If it is in pre-hospital, we have
No, not pre-hospital. He is in the ER. He vomited like 500 cc in front of you, and his blood pressure is 60 systolic.
Same, sir. Primarily, we will try to secure the airway, then Senstagen tube.
Yeah, how do you secure the airway?
We are using salad technique.
Okay, so what medicine will you give?
You mean for induction?
Yeah.
For induction, I would still choose ketamine, sir.
Yeah, so what I am saying is ketamine alone, how much dose will you use?
0.5 mg per kg.
That is not it's not going to increase the blood pressure that much. So what I am saying is this patient I had, and I used phenylephrine, push dose pressure to bring the blood pressure to 100, transiently, and then intubate the guy. Yes. Because if you don't do that, 60 hypotension, he will be in cardiac arrest.
Yes, sir. One of the JR who is sitting there is doing the similar thesis.
Yeah. And
he is doing push dose pressor.
Yeah. So that's what I'm saying. This patient, 60, I had a patient, many years ago, 10 years ago, I had a patient. Yes. He vomited 500 cc's in front of me, and his blood pressure was 60.
Yes.
And the endoscopist, GI was there. He said, intubate, I will do the endoscopy.
Okay.
So I intubated, he did the endoscopy and did ligation of the varices. So that's fine. And another thing is, what if it is not variceal bleed? We have a lot of patients with peptic ulcer with active bleeding, So in that, we had done, I had a patient, and we did what is called triple phase GI contrast CT. It showed a bleeding, active bleeding. And the interventional radiologist embolized it and stopped the bleeding. That's it. No more bleeding. It stopped like that immediately. So you have to be, So
we should be thinking. For that, again, resources is the limiting thing in India.
Yeah, IR is there, right?
IR is available in some tertiary centers.
You are from AIMS.
AIMS it is available.
Yeah. So they can do it. I'm just saying.
Yes.
That is also thing. You can do endoscopy also, but you have to think about other causes of
Yeah.
massive GI bleed. Yeah. Okay, good. Very good presentation. Excellent.
Any question?
Thank you, Dr. Manish, for that excellent and clinically enriching session. Your insights highlight how timely risk assessment can significantly influence outcomes in these high-stake emergencies. Now, we shift our attention to metabolic emergencies, where disturbances in blood glucose levels can rapidly become life-threatening. For discussing this important topic, dangerous dysglycemia, management of glycemic emergencies in the emergency department. Please join me in welcoming Dr. Parvati S., MD Emergency Medicine, Senior Resident at Dr. Mupin's Medical College, Wayanad.
Good afternoon, everybody. I'm Dr. Parvati. So, welcome to the next session of Broad Reviews in Emergency Medicine. At this outset, I would like to thank AME and the organizing committee for this opportunity. So, without much delay, let us go straight into the topic. Dangerous dysglycemia, the management of glycemic emergencies in ED. This is a case scenario. We have a 58-year-old man who is brought to the emergency department by the family with altered mental status for the past 6 hours. The presenting complaints were increasing polyuria, polydipsia for 4 to 5 days, progressive weakness and lethargy, confusion since morning, and reduced oral intake. The past history showed that he was a type 2 diabetes mellitus patient for past 10 years and on OHs, and he was recently treated for pneumonia around 1 week ago. This is the primary survey of the patient. What are the abnormalities that we can spot in this one? We can see that the patient is tachypneic, but he is maintaining the saturation. The circulation part shows us that there is tachycardia, the patient is in shock. The GCS is also, the GCS is not full, E3, V4, M5. The RBS is raised. So if we have to go with how we are going to approach this case, there are so many differentials that we have to discuss. But at times, what we tend to see is that in the ED, we'll be like, okay, what are the vitals? The patient, what is the BP, what is the heart rate? And sometimes it stops there. Sometimes the RBS part gets ignored. I would say that hypoglycemia still will get noticed, but at times hyperglycemia gets ignored. So that is that cannot be accepted, because once we diagnose it early, we can save more lives. So in this patient also, we will go about with the point of care investigations. A blood gas was done for the patient, and we can see there is severe metabolic acidosis in the patient. So why are we discussing this? The global trends and epidemiology. There's a rising burden, that is around 55% increase in the rate of DK hospitalizations in the past decade, and this was particularly more common in patients, the adults who are less than 45 years of age. The ED reality is that around 1% of the hospitalizations for diabetic patients, that is for hyperglycemic emergencies. And around 27% of the patients have a combined presentation where that is a DK plus HHS state. The mortality associated with DK is less than 1% in the high income country, but it rises up to around 41% when it comes to low and middle income countries, and HHS, it is around 5 to 10% for higher mortality. It is not possible to discuss the pathophysiology of DK and HHS in detail, but the one single thing that we have to remember is that if we have to remember the two players, insulin and the counter hormones. The common driver in both HHS as well as DKA is that there is absolute or relative deficiency of insulin and a surge in the counter regulatory hormone, which include glucagon, catecholamines and cortisol. In DKA, there is a ketogenic triad where there is severe deficiency of insulin and there is lipolysis and hepatic fatty acid oxidation, and this will result in ketosis and acidosis. But in HHS, the residual insulin, that is enough so as to prevent ketosis, but it is not sufficient to prevent hyperglycemia. So there is there is no ketosis, but there is hyperglycemia, and there is profound osmotic diuresis that is resulting in severe dehydration in the patient. So what we are going to discuss here, it is the updated ADA guidelines from the 2024 publication. So what is DKA? How will you diagnose that the patient is in DKA? So I have given it as DKA redefined because there has been some changes from the past criteria that was followed. The first one, glucose threshold that has been lowered to more than equal to 200 milligram per deciliter, or even a non-history of diabetes is enough. Not always the sugar levels are important. Like, of course, if it is more than 200, that is a diagnostic criteria. But even if the patient is having a history of diabetes, even that becomes important here. The gold standard, that becomes ketones. Focus on the blood beta hydroxybutyrate value. If it is more than equal to 3 millimole per liter, that is diagnostic of ketosis in case of a DKA patient. Urine ketones are less specific. We always tend to do the urine ketones, but it is less specific. They tend to lag behind, and therefore blood ketones are to be preferred. Acidosis, a venous pH of less than 7.3 and a bicarbonate value of less than 18. So 3 things: a glucose more than equal to 200 or a history of diabetes. Ketones more than equal to 3 millimole. Which ketone? That is serum ketone or the blood ketone that needs to be done, and note the urine ketone. Acidosis, a pH of less than 7.3 or a bicarbonate of less than 18. So that is DKA. Now coming to HHS, the diagnostic pillars, again 3 things: hyperglycemia of more than 600, hyperosmolality, where the effective serum osmolality is more than 320 milliosmol per kilogram, and there is profound dehydration in the patient without significant ketosis or acidosis. The pH is more than 7.3 and the beta hydroxybutyrate levels, it is less than 3 millimole per liter. So that is how we diagnose HHS. But as we have discussed earlier, around 27% or 30% of the patients, they are going to present to you in a mixed state of DKA plus HHS state. Coming to the severity stratification and the level of care. So we have categorized DKA into mild, moderate and severe. When we have a patient with DKA, we know, like when we see the management, we already know that we are going to give fluids to the patient, we are going to give insulin to the patient. So what makes it important? Why do we actually need to categorize them into mild, moderate and severe? In this table, I would like you to focus on two things actually: ketonemia and acidosis. That is where all the differences lie. So ketonemia, we have already discussed that for the diagnosis, the beta hydroxybutyrate levels should be more than 3 millimole per liter. So if it is mild or moderate DKA, it will be 3 to 6 millimole per liter. But in case of severe DKA, it will be more than 6 millimole per liter. And secondly, how will you categorize the patients based on the pH values? When the acidosis, we already know it is less than 7.3. So when the pH is 7.25 to 7.3, or a bicarbonate value of 15 to 18, that becomes a mild DKA. pH of 7 to 7.25 or a bicarbonate of 10 to 15, that will make it moderate DKA. And when the pH is less than 7 and the bicarbonate is less than 10, that will become a severe DKA. Now why do we need to categorize it? As you can see in the table itself, it has been given. This suggested level of care is different for mild, moderate and severe. In a mild DKA, you can manage the patient in a regular or an observational nursing unit. Even in the ED, that is enough. But a moderate DKA has to be treated or managed in an intermediate care unit. And when it comes to severe DKA, an ICU management is required. And note to mention that HHS, like we have already discussed in the initial slides, that the mortality associated with HHS is around 5 to 10% in more than that of a DKA patient. So therefore, the HHS patient, of course, has to be treated in a ICU. Now coming to the management of hyperglycemic emergencies. 4 pillars: fluid replacement, insulin therapy, electrolyte depletion, and identification and treatment of underlying precipitating events. So first, fluid resuscitation. What to give, how to give it. So isotonic saline remains the standard initial therapy, but the recent the ADA guidelines show that balanced crystalloids, that is RL or plasmolite, it is an acceptable and increasingly favored alternative because there is faster DKA resolution, shorter hospital stay, as well as lower incidence of hyperchloremic metabolic acidosis. And what will be the initial rate of administration? Imagine you have a patient there with no renal or cardiac compromise. You can start with 500 to 1000 ml per hour and you can continue this for around 2 to 4 hours. But after that, we have to titrate the fluid for the patient based on his hemodynamics, the urine output, the corrected sodium and the comorbidities. While we discuss the mild, moderate and severe decay, another implication that it has on our management is that the amount of fluid deficit is also something that is variable. So, as an umbrella term, we say that okay, around 6 liter of fluid deficit in decay and around 9 liter in HHS. But when it is mild, moderate and severe, again there is variation. How will you calculate the amount of fluid deficit? Like even that is dependent on the dehydration that the patient has. If it is a mild decay, it is around 3 to 5%. In a moderate decay, it is 5 to 7%, and in severe, it comes up to 7 to 10%. So again, the amount of fluid that you have to give to resuscitate the patient is also something variable. So the dextrose, whenever the plasma glucose is less than 250, you are going to switch the IV fluid to a dextrose containing one. Why do we need to do that? Because here we are not just treating hyperglycemia. What we need to treat? We need to treat acidosis and ketosis. And what will help us treat the acidosis and ketosis? It is definitely the insulin infusion. So we have to continue the insulin infusion. So to bridge that, we don't want our patient to be in hypoglycemia, so we are bridging it. We are giving dextrose containing fluid and we are maintaining the sugar value so that we can continue the insulin infusion to treat acidosis and ketosis. Now some special situations. When you have a patient with heart failure or a end-stage renal disease, there use smaller boluses of around 250 ml and frequent reassessment is required. What if the patient is presenting, like the initial case, the patient was in shock? What if the patient is in shock? There is no guide, like the ADA has not mentioned this specifically, but of course you can start the patient on 15 to 20 ml per kilogram per hour fluid, and around 1 to 1.5 liter will go in the first hour, and then we can again reassess and titrate the amount of fluid. In pediatric patient, the initial rate is 10 to 20 ml per kilogram per hour and the maximum dose of 50 ml per kg over the first 4 hours. Here the risk of cerebral edema is even more as compared to adults, and therefore the purpose is to reduce the risk of iatrogenic cerebral edema. Insulin therapy in decay and HHS. The general principle is that the cornerstone of decay management is insulin therapy, and it should be initiated as soon as the diagnosis is confirmed. So you have a patient, you have diagnosed that it is decay. Will you start insulin straightforward? No. The only one thing that you have to see before starting insulin is that it should be the potassium value, and it should be more than equal to 3.5. And the insulin infusion should be continued till the ketoacidosis resolves. How to give insulin? IV is the preferred approach. A fixed rate of infusion 0.1 unit per kilogram per hour, and initially we used to follow a bolus dose. Right now it is not recommended. You can start the patients straight on the infusion. If it is an HHS, you don't have a mixed presentation, it is an HHS, the rate of insulin infusion will be 0.05 unit per kilogram per hour. Can we skip giving insulin infusion? If you have a patient with mild, uncomplicated decay, in such a case, we can also give subcutaneous insulin, and that can be repeated every 1 to 2 hours. And this is an effective alternative to IV infusion. Basal insulin continuation strategy, co-administration of low dose, that is around 0.15 to 0.3 unit per kg of IV insulin is recommended, because that has shown to shorten the time to decay resolution and prevents the risk of rebound hyperglycemia without increasing the risk of hypoglycemia. Electrolyte repression, we have already told, potassium is the major player there. The critical safety rule is that the delay the insulin therapy if the potassium value is less than 3.5. Correct potassium, once it is more than 3.5, start insulin. How to give it? We have to give around 10 millimole per hour. So what we usually do is that for every 1 liter fluid that the patient is receiving, add around 20 to 30 millimoles, supplement 20 to 30 millimoles of potassium, and it has to be maintained between 4 to 5. The adjunctive therapies in the management include bicarbonate. Will we give it to all the patients? There is a definite criteria. If it is the pH is less than 7, you can consider supplementing bicarbonate. It is to be given as 100 milliequivalents in 400 ml of sterile water, and that has to be infused over 2 hours. Bicarbonate push is not recommended. Infusion over 2 hours is what is recommended. Phosphate, again, routine administration is not indicated. Replace if the serum phosphate is less than 1, or if it is symptomatic, the patient has respiratory compromise, the patient develops muscle weakness. In that case, we can consider supplementing phosphate as well. they target early changes. In DKA, the glucose reduction should be 50 to 70 milligram per deciliter, and in case of HHS, 90 to 120 milligram per deciliter. The potassium, again, in both, it has to be maintained between 4 to 5. The sodium, we know, what we see initially, it may not be the correct value. There, with hyperglycemia, the value of sodium tends to fall. So, as you correct the hyperglycemia, as the glucose level comes down, we expect a rise in the sodium values. Osmolarity, it is not applicable in case of DKA, but in HHS, 3 to 8 milliosmol per kilogram per hour is the target reduction. Monitoring, what to check, how frequently you should check it. Capillary glucose, as we know, 1 to 2 hourly we have to check. Initial potassium check should be done for the patient after initiation of the insulin, after 2 hours after initiation of the insulin. And all the lab parameters, the electrolytes and the serum osmolarity, including the beta hydroxybutyrate, should be rechecked every 4 hours. The clinical pearl, insulin is what is going to treat your acidosis. Potassium is something that is going to determine the timing of insulin, and potassium will prevent the cardiac arrest. Criteria for resolution, DKA, we tell that it is resolved if the beta hydroxybutyrate value is less than 0.6, venous P is more than 7.3, and the bicarbonate value is more than 18. HHS, serum osmolarity has fallen to less than 300. The cognitive status has improved and the stable blood glucose levels have been achieved. Overlap, as we know, around 1 to 2 hour overlap should be there between the subcutaneous regimen and the discontinuation of the IV regimen that is going on. So that was one end of the spectrum. Now you also have patients who come to you, they are crashing in front of you, and you find that the patient is in hypoglycemia. How will you approach such a patient? So coming to the ADA definition of hypoglycemia, there are 3 levels, level 1, 2 and 3. Level 1, when the glucose value is less than 70. Level 2, when the glucose value is less than 54. And level 3, this is important, that is irrespective of, regardless of whatever the glucose value be, a severe event that is characterized by altered mental sensorium, or basically we can just remember that the patient required assistance from another person for recovery. In that case, irrespective of the glucose value, the patient had a severe level 3 hyperglycemia. Hypoglycemia in patients with diabetes, the common causes insulin, nutrition, comorbidities like CKD, sepsis, CLD, and other OADs like sulfonylureas can be there. But if the patient is not a diabetic, he is not, then the first causes that we have to think about, it might be an endocrine cause where there is adrenal insufficiency, hyperthyroidism, or insulinoma, and of course these remains the same, the nutrition, the comorbidities, and accidental in the intake of the insulin or other OHs. So clinical assessment, how are you going to approach the patient? There is an every encounter rule that is given in the ADA guideline. Review hypoglycemia history at every clinical encounter for all high-risk individual, and whenever it is warranted, we have to actively screen the patients. You have a patient, the glucose levels are low, but the patient is conscious. How will you treat it? The first choice here becomes oral glucose. You can give 15 to 20 gram. That is preferred for a conscious patient. Here, we have to remember the 15-minute rule. You have to give the treatment, administer glucose, wait for 15 minutes, and then recheck the glucose. And if the patient is still hypoglycemic, you can repeat the treatment. What if the patient is hypoglycemic? You have a patient, the glucose value is 40, the patient is unconscious. Will you give 100 ml of D25 or 2? How much amount of D25 needs to be given? The dose is 0.3 to 0.5 gram per kilogram of IV dextrose. And once we convert it into the different formulations that we have, and according to that, if you are giving D25, around 1.2 to 2 ml per kilogram is what needs to be given. That is why when we have an average adult, we are giving 100 ml of D25. So this is the same. Again, you have a patient unconscious, you are giving IV dextrose to the patient. Wait for 15 minutes, recheck. If it is again on the lower side, you can consider giving the IV dextrose again. But if it is recurrent, evaluate, simultaneously start your evaluation for recurrent hypoglycemia. Whatever causes were discussed earlier, that needs to be evaluated. Now coming to severe hypoglycemia, you are supplementing dextrose, but again the patient is going to hypoglycemia. What is the next step? What can be given? Glucagon. It is useful in patients with severe hypoglycemia who are unable to take orally. Another advantage is that you have a patient, you don't have an IV access, the patient is unconscious, but you are unable to secure an IV access. Glucagon can be helpful because it can be given IM as well as subcutaneously. So the adult dose becomes 1 milligram, that is reconstituted in 1 ml of sterile water. In children more than 25 kg also the same dosing. If the child is less than 25 kg, 0.5 milligram. So severe hypoglycemia. Now ADA has recommended that glucagon should be prescribed for all the individuals taking insulin or who are at high risk for hypoglycemia, and the formulation should be such that it can be easily used by the patients, and proper education should be given to the patient, the family and the caregivers. Re-evaluation mandate: whenever there is level 2 or level 3 hypoglycemia, there must be immediate re-evaluation treatment plan, and the clinical response must be, maybe we should consider de-intensifying the treatment, switching to medications that will not cause the hypoglycemia or maybe lower the risk of hypoglycemia, and also other causes of hypoglycemia should be evaluated. Role for CGMS, continuous glucose monitoring. It is useful in patients who are at risk of hypoglycemia to detect and prevent hypoglycemia, but it is to be used in caution if the patient is in shock or in poor perfusion state. So that is recommended in patients who are at high risk for hypoglycemia. So these are all the aftermath of hypoglycemia. The cause, whatever precipitated hypoglycemia, needs to be evaluated. The modification needs to be done. Frequent and appropriate monitoring of the blood glucose, and relax the glycemic target for the next 2 to 4 weeks at least, and troubleshoot what went wrong. Was your dosing wrong? Is the requirement low? Whatever it is, that needs to be corrected. So you have a patient with critically ill patient. How will you do the glucose monitoring? A diabetic patient who is on basal bolus, 4-point monitoring is required. If the patient is having a fairly good control, you can go for 2-point monitoring, and if it is not so good, switch to 4-point monitoring. If the patient is on insulin infusion, 1 to 2 hourly monitoring, and in DK and HHS, as we already discussed, there is 1 hourly monitoring needed. Thank you.
If somebody has sulfonylurea taking and they are hypoglycemic, you give D50 and they are again after some time becoming hypoglycemic, what do you do?
Octreotide is a possible
so
medicine that can be given.
octreotide can be given, that is very useful, number one. And second thing is type 2 diabetes, if you give D50, sometimes what happens, if they are producing insulin, they can get reactive hypoglycemia. So you might have to give them something to eat, or you might have to give D10 drip, because otherwise they will go into hypoglycemia again. Okay. So how do you calculate serum osmolality in non-ketotic hyperosmolar coma? So what is the formula?
2 into measured sodium plus blood glucose by 18 is the effective serum osmolality.
Yeah, so say if somebody's sodium is like 120 and their sugar is 1200 and BUN is 40. BUN is 40, their blood sugar is 900 and their sodium is like 124.
2 into 124 plus
So what you have to do is you have to correct it. Corrected sodium, not the measured sodium. So how do you correct it?
For every 100 milliequivalents rise in the glucose value above 100, 1.6 is the expected rise in sodium.
Yes. So if it is like 1200, then you have to 11 into 1.6, So you might have to increase by 18, when you are calculating the osmolarity. That's very important, because then only you will get more than 320 for the non-ketotic, So I see people making mistakes and not correcting the. Okay, very good.
Thank you.
Thank you, Dr. Pal.
So how about patient with not meet inclusion criteria of DK and HHS, patient with uncontrolled hyperglycemia with 500 or 530 blood sugar? So how do we approach in such patients?
First thing, you have to rule out DK and HHS. Once that has been ruled out and you are sure that the patient is critically, you have an IP patient who is critically ill, even in that case, IV insulin can be given for the patient. But the monitoring needs to be that frequent. Maybe in that case, you can go for 1 or maybe 2 hourly monitoring of the glucose. The principles remain the same. If you are giving IV insulin to a patient, you have to supplement potassium. Otherwise, you are going to kill the patient because he is going to develop arrhythmia due to hypokalemia, and you are going to kill the patient. So, you have ruled out, even if you have ruled out DK and HHS, and if the sugars it is coming up, it is high, it is persistently high, it is 500, it is 400, you can consider giving insulin to the patient. But there, this aggressive monitoring, like we don't have to be like that cautious when you are giving fluid. Like we have to give fluid, we can give insulin, but the monitoring that will not be that aggressive as case of a DK or HHS patient. But don't forget, here also you have to supplement the patient with potassium. If you are giving insulin, you have to supplement potassium as well. Thank you.
Thank you, Dr. Parvati, for that informative and enlightening discussion. Your presentation reinforces the importance of vigilance and timely intervention in managing glycemic crisis. Emergency medicine often requires a rapid decision making under pressure. In such moments, understanding how we think and how we arrive at diagnosis becomes just as important as the diagnosis itself. Our next session explores the concept of reflective clinical reasoning. Trust but verify. Cognitive autopsy for better diagnosis in the emergency department. Please welcome Dr. Vinayak SR, Department of Critical Care Medicine at Aster Med City, Cochin.
Hello. So how many of you here have made at least one mistake at some point in your clinical career? No one? Yes, you've all made mistakes. Now, how many of you have gone back to your mistakes and actively trying to learn as to what went wrong and corrected upon it? Not so much. We usually like to talk about our wins, like, the rare diagnosis that we got, the tides turned, and lives saved against all odds. But what about the ones that we didn't? Like the misdiagnosis, errors in judgment, and the patients who didn't make it. And oftentimes this failure, it's uncomfortable. We don't want to go back to all those trauma. And it's also a great teacher on the other hand. So what we're going to do today is we're going to take a step away from all those success stories, and we'll talk about something that we rarely discuss. That is how these cognitive biases, how they shape our decisions, and how they lead us astray, and how a cognitive autopsy can help us learn from our mistakes and help us become better clinicians. So what we're going to do is we're going to discuss a few cases. We'll start with one. This was a case I had during my residency. I had a 70-year-old lady who was brought to the ED in an altered mental state. Her heart rate was 70 per minute. Blood pressure was fine. Saturations were normal in room air, but her blood sugars were profoundly low. It was just 50 milligrams per deciliter. Obviously, the first thing that was I thought was you had to give 25D. So she was diabetic on insulin. She had metformin, glimepiride combination. So I gave a 100 ml bolus of 25% dextrose and advised oral feeds after that. After that, she regained her sensorium. But her bystander was actually her caretaker. They didn't want to stay there any longer. She was like, yeah, this happens all the time. We want to go home. And she wasn't willing for any further workup. And at the same time, she was in the red zone, and the red zone got crowded all of a sudden. So we had no other option but to down triage her to yellow zone. And we completely forgot about her. And what happened was, about 1 hour later, she showed signs of distress. Her heart rate rose, her BP plummeted, and her saturation was not recordable, and she had to be triaged back to the red zone. And an episode of sudden posturing later, she suddenly became unresponsive and went into cardiac arrest. And some of you might be knowing what could have happened in this situation, so we'll do a deep scan of this once we do a brief overview. So why do we want to talk about diagnostic failure? Diagnostic errors, these actually account to up to 10 to 15% of medical mistakes, and these can result in significant morbidity and mortality as well. And our specialties, because of the way it works, is highly prone for it. Now, why do we make these mistakes? Now, every time we make a mistake, the first thing that pops up in our mind and in the other's mind as well is that we don't know stuff. That is limited knowledge. But when you come to think of it, limited knowledge is only a part of the problem. What actually happens is, especially for the emergency physicians here, is there is a particular unique operating characteristic that works around in the emergency department. And also, You know how we work, right? We make split-second decisions under pressure, but sometimes it is not just the disease that beats us. What happens is it's our thinking that beats us. And cognitive biases, these also result in mistakes. So these subtly change our diagnosis and often it leads us down the wrong path. And what happens, because of that, you make diagnostic error. So we'll explore more on these biases today, dissect real cases, and we'll learn how these doing a cognitive autopsy can help us make better decisions and help save lives. So what are the unique operating characteristics of an ED? First is there is a high level of diagnostic uncertainty. You have a patient who was brought in with sudden onset breathlessness. All you know about that patient at that point is probably the age, sex, and the fact that he or she has breathlessness. You know nothing about her medications, her history, nothing. So you have a very limited time to get that history as well. So with all this limited information and limited time, you have to manage this patient. Then there is high decision density. Think about a normal ED shift. How many decisions do you make? I have to give an insulin bolus. I have to order potassium for this patient. I have to order an ECG. I have to call the cardiologist. Like that, numerous decisions have to be made during a shift. So that will lead to a high decision density. In addition to that, there will be a high cognitive load as well. So what happens is, on top of the decisions you make, there is a significant amount of background information to bear on those decisions, like your large differential diagnosis, the investigations that you have sent that you kept in your mind, your examination findings, and what you can do to minimize all this is maybe you can follow certain algorithms. And obviously, ED has a very high level of activity ongoing. In the ACLS, you already might have known, a chain is only as strong as its weakest link. So depending on the levels of experience of you, your residents, your interns, your staff, nursing staff, the quality of care might get compromised. So if you have inexperienced staff among you, the quality can significantly plummet. And ED is an obvious, there are multiple possibilities of interruptions and distractions while you're in your shift. Like maybe you are aggressively managing a patient in shock, and at that time the nursing staff from the yellow zone will be like, sir, we have a patient over there who's complaining of abdominal pain, what do we do? So what you try to do at that point is you try to send her away as fast as possible. So you maybe just prescribe some analgesic. So what might be happening over there is something entirely different. So that can also lead to multiple mistakes. There could be uneven and abbreviated care. That is exactly the reason why you have to properly triage patients. And the problems associated with shift work and shift changes and compromise teamwork. Finally, there is poor feedback because most of the patients either get discharged or get admitted, but we don't usually go after them to get a proper feedback. So that can also result in mistakes and medical errors. Now, before moving on to cognitive autopsy, let's see how we actually think. The human mind, that is, the way we think is kind of unique. There are two systems in play here. The first one is rapid and intuitive, like your unconscious, reflective, which is based on past experience using heuristics. This is what we usually apply in the ED. And on the other hand, there is another system which is slow and deliberative. That is where we measure, where it's analytical. There is a high cognitive effort involved and a cognitive activity is also needed. I'll show you with an example. We have a 45-year-old male with chest pain. Diagnosis? STEMI. So it took 3 seconds for you guys to diagnose, right? So that's your part, your fast thinking. Now we have another case over here. An 87-year-old male with syncope, which was actually a case of cough syncope. Every time this patient tried to cough, he had an episode of syncope. Diagnosis? Okay, this time you have to think, right? You have to think a lot because there's a broad differential involved. So these are the two types of thinking that you have. So this is another case I encountered. We tried to evaluate what went wrong, but we couldn't find an answer, so we had to admit this patient. And later on, one cardiologist came to us, hey, remember that case you shifted to our facility? Turns out he had this. It was a case of massive pericardial effusion, which we failed to diagnose in the ED because maybe due to multiple reasons, but this was ultimately the diagnosis. Yeah, it wasn't noticed because the patient was triaged to a yellow area at that point. And at the yellow, we tried to dispose the patient off as early as possible because it's just a case of syncope. Yes.
The syncope is this thing I wanted to tell you about this pericardial like cardiac phenomena. Another causes of
Syncope.
low voltage no fluxes with electrical alternates. have to look low voltage complexes with electrical alternates. You have to think in syncope. I forgot to tell that. Yeah.
So this was the case with syncope. So what are the common cognitive biases that we encounter? So I went through this wonderful article on Curious. In this article, what it is, they anonymized around 30 cases, and what they found was around 24 cognitive plus affective biases, and each case had about 5 to 6 biases. And there are about 13 plus error producing conditions like sleep deprivation, fatigue, high stress situation, corridor consultation, and so on. So we'll move on to certain biases that we commonly encounter. First is anchoring bias. So what is anchoring bias? Anchoring bias is where you focus on specific elements of a presentation way too early in the diagnostic process, and what happens is it results in evaluating the likelihood of a particular outcome based on the initial information encountered only. For example, we had a patient who was post-op, like he had a fracture of the femur, post-op, day 2, he was brought to the ED with severe pain and swelling. So what crosses your mind immediately? It's a DVT. So we also thought about DVT. So my mind was fixated on DVT. So I had to send dimers, he had to do a point of care ultrasound. I did a point of care ultrasound, there was nothing. So it actually turned out to be a case of compartment syndrome. It wasn't a DVT. So that is what happens when you anchor onto that particular thing. My mind was fixated on the fact that he underwent a surgery. So surgery, DVT, pain, swelling, all fixed. But it turned out to be a case of compartment syndrome.
So one thing to prevent anchoring bias is always, even if something is obvious, you have to always think what could be the differential.
Yes.
What other things could be there? Because something is obvious. We are not going to miss that. He's not going to miss the DVT, but he can miss something else. So you have to always think about the differential diagnosis. What if it is not DVT? What else it could be? And then, because when you have an anchoring bias, all the findings will be positive for your, you will ignore the negative things. You will always think, okay, it is swollen, it is post-operative, this, that. So you will be always thinking things in favor of DVT, and you will never think about, okay, what could be a compartment? Let me do a passive stretch of the toes or whatever, So that's very important. You have to always, even if it's obvious, you have to think, okay, even if it is like an inferior MI, I sometimes think, is it a dissection causing the inferior MI? You always have to think. I'm not saying you have to, but you have to think about the differential. Otherwise, you will miss.
Yes, sir, that is perfectly put. Now moving on to the next bias, it is confirmation bias. It is somewhat similar, but here what happens is it shows we show tendencies to seek evidence that supports our existing hypothesis rather than looking for evidence that contradicts it. So what happens is, because of that, you will focus more on data that seem relevant to the existing beliefs that you already had, and it will result in a satisfactory but suboptimal outcomes. Like in a difficult case, you find a confirming evidence and it feels good. But at the same time, you will find some disconfirming evidence which will undermine the hypothesis. It means that you will have to think all over again. It means it's more effort, so you won't do that. So that is confirmation bias. What happens is it will lead to adding up of redundant data, and it will bolster your confidence. There's a good example for that. I had a young female. He was brought to the ED with altered sensorium, bradycardia. Bradycardia, we evaluated, it turned out to be hyperkalemia, and she was anuric. There was an AKA as well. So there is bradycardia, hyperkalemia, AKA. So my mind got fixated on AKA. Now I was trying to figure out what caused the AKA. What caused the AKA? So I went back to history, and they were like, she stood out in the sun for like 5 minutes and had a syncope 2 days back. Could be a rhabdo. Okay, it's rhabdo. So it's rhabdo AKA. We'll call the nephrologist. And in the meantime, we had sent all the other labs as well. And the LFT had apparently turned grossly abnormal, but we didn't pay much attention to it. Turned out we took a proper history, we sent the tox screening and all that. It was a case of paracetamol poisoning, which presented this way. So a primary paracetamol poisoning, multi-organ failure resulted in AKA, hyperkalemia, bradycardia. So that is what happens when confirmation bias occurs. Then there is diagnosis momentum. Here what happens is, you have a tendency for a particular diagnosis to become established without adequate evidence. This usually happens when you get a patient referred from elsewhere. Sometimes you get a patient referred from a peripheral center. I had this patient. It was a 50-year-old lady, so she was brought on a BiPAP with shortness of breath. And on the referral letter, it was written, hemoptysis since today evening. And so, okay, hemoptysis, BiPAP, shortness of breath. On auscultation, yes, crackles were present, but again, here my mind was focused on hemoptysis. So what could cause hemoptysis? Could it be a pulmonary embolism, ARDS? What could it be? What could it be? Actually, her blood pressure was around 200, fine Krebs, B profile. It was a simple case of hypertensive heart failure. So what happened was she coughed out in the previous center, and it was pinkish. So they assumed it to be hemoptysis. Because they wrote hemoptysis, my mind was fixated on hemotherapy. That is what happens, diagnosis momentum. You find something, you go along with that. And then there is premature closure. Premature closure is what happened in the initial case. So you accept a diagnosis way too early without considering any alternatives. So you have to use broad differences to be prior to that. There is triage queuing. So here, your diagnosis, it may be influenced by an early judgment from the triage staff who only provided brief care, like our syncope patient, and any biases or cognitive tendencies that the physician already has will be significantly heightened during this. We had a patient, a 61-year-old male, abdominal pain. At the triage, his vitals were perfectly normal. And I got a call from an intern saying that, yeah, the patient looks kind of tense. Do you want to see him? Yeah, I'll come back in 10 minutes. And then I went back. He was actually tense in the abdomen. He wasn't moving an inch. He looked perfectly fine, but he wasn't moving an inch. His abdomen was tense. This is what it was. It was a massive pneumoperitoneum due to perforation. They had to do a resection, and unfortunately, this patient also did not make it. Although we didn't delay the diagnosis by much, but it could have been fatal earlier on had we missed it. Now, what are some of the other predisposing factors that lead to errors? Obviously, there is fatigue, sleep deprivation, high stress situation that we commonly encounter in the ED. There is corridor consultation that we, like the one I just mentioned. And there is error at the level of handover and transition of care. When we give handover to the next physician on duty, what happens is, it's inevitable. A certain amount of information always gets lost. And when that information gets transferred again, further information gets lost. So how can you solve that? The only thing you can do is, you can use a handover sheet perhaps. So you can write things down as to what the other person said. You can't memorize all the things. So what I do is I write things down. That's the only way to escape from this. Now what? How many patients will you hand over? Depends on the, depends on how busy the ED is. That's what. And then there is problems associated with shift work, like shift work causes fatigue, ill health, acute and chronic sleep deprivation, which leads to neurocognitive deficits and negative mood states. And the time spent on your task will be sustained, and ultimately all these result in decision fatigue. So how do we learn from these errors? That is where we apply your cognitive autopsy. It's simple. What we do is we do an in-depth analysis of the case. So how do we do that? And you have to encourage reflection to understand their clinical reasoning and decision making through their participation of all the clinicians. It's a stepwise approach. First step is you describe the case. Next, you identify what the key decision points were. So once you've identified those, you analyze what cognitive biases were in play. And then you develop corresponding corrective strategies. So what happened? What was the error? So we'll go back to our case, a 70-year-old female. She had hypoglycemia, she was a diabetic. She also had a history of fever, vomiting, fatigue, and lower abdominal pain since 2 days. And following her hypoglycemic correction, although her mental state was normal, she complained of abdominal discomfort. So what were the key decision points in that case? First point, diagnosis and treatment of hypoglycemia. Second, discontinuation of further workup, because they wanted to go home, and that sort of heightened our biases at that point itself. Down triaging the patient back to yellow and attempting to get a proper contact with bystanders. That was done only when the patient destabilized, and then retriaging back to red. Now, if we analyze what were the biases at play here, obviously there was anchoring bias. We did not think about broad DDs. We fixated on hypoglycemia. Again, search satisfaction was present at that. We got satisfied because we got an answer to our alternate mental state. It was hypoglycemia. So we got satisfied there, and that itself was a bias. Then there is premature closure as well. And obviously, certain unique operating characteristics of ED were present at that point because of the heavy rush at that point. Now, what corrective strategies can you employ? First, you can do broad differential diagnosis, like what else could it be at the end of your final diagnosis. That is the main takeaway message in this particular case. What are the other things that you can do to minimize errors using checklists? So we had a patient, it was a 36-year-old male who sustained gunshot injury to his chest, and there was a pericardial tamponade, and we did a needle pericardial stendosis, and the tamponade was relieved. And now think about it, it's a very high rush, high adrenaline situation, and it was so gratifying that the patient improved. And what happened was 6 months down the lane, we did an audit, a trauma audit, and what we found out was that we did not give TT to this patient. What happened was we did not consider this patient as a routine trauma patient, so we did not think about TT at that point. So how can you avoid such mistakes? That is where checklists come into it. This is one such example. This is a WHO trauma checklist. Here, if you go all the way down, you'll notice that there is an option where they ask you whether TT has been provided or not. So that is one way to avoid mistakes. Another way to prevent errors is following protocols. There was another patient, a 40-year-old male. It was a body trauma victim who was stabilized in another center and then referred to our center. He was intubated with bilateral tubes in place. A unit of PRBC was on floor, the MAP was maintained at 70 with a heart rate of 60, and saturation was maintained. But this patient went into cardiac arrest 15 minutes into our presentation. We revived with about 2-3 cycles. And what was unique was, again after 10 minutes, the patient went into cardiac arrest. This time we managed to get an ECG, and this is what the ECG looked like. We couldn't find a cause as to what caused the arrest because there was no hypoxia, there was no hypovolemia. This is what the ECG showed. Any idea what it could be? Yes? So, it's cardiac arrest. What comes to your mind when you think about cardiac arrest? American Heart Association. It's the ACLS. Think about your ACLS mega code. It's your 5? Yes, 5 Hs and 5 Ts. Now go back to your 5 Hs and 5 Ts. Think about the fact that this patient is in a tropical state. So what you see here are Osborne J waves. It was a case of hypothermic cardiac arrest. You don't normally see hypothermic cardiac arrest in our country, especially in this part of the country, but this was a trauma victim who had hypovolemic shock. So they are prone to develop hypothermia, and this was the cause of cardiac arrest in this situation. Once we rewarmed the patient, there was no further events, further cardiac arrest. So always follow your algorithms, not just when you're at a standstill, from the beginning itself. Next thing you can do is you can use your scoring systems like your Wells score for DVT, pulmonary embolism, your heart score. All those will help in risk stratifying and also to an extent diagnosing your cases. So in your department, what can you do to improve your diagnostic accuracy and reduce errors? Get proper feedback, get proper follow-up. There must be a culture of non-punitive learning and open discussion. So your mortality means it should not be about blame gaming. It should be about open discussion and learning. And you have to incorporate cognitive autopsy as well into your mortality meetings. So emergency medicine, it's all about rapid decision making, but this rapidness or this speed, it should not come at the cost of diagnostic accuracy. So these biases, they are inevitable. So, but that doesn't mean they have to define our practice. The key is awareness. So you have to recognize when our thinking is leading us astray. You have to question our first impressions, and you have to be open to considering a different diagnosis. So it's not completely about blame. It's about learning, improving, and ensuring that the next patient gets a better outcome because we took the time to reflect. So we usually celebrate our wins, but let's also learn from our losses, because in the end, the best clinicians, they aren't the ones who just save lives, but they are the ones who never stop learning. Thank you.
Excellent talk. Anybody has any questions?
Or would anybody like to discuss any case that they sort of made a mess of and would like to discuss about it?
I would congratulate Dr. Vinayak at this young age for bringing up this topic and presenting so boldly the mistakes. When usually in young age, everybody feels there are no mistakes. And if at all some mistakes happen, nobody speaks out. So I think it's a very good presentation, and you have boldly presented. Keep it up. And sir has rightly supported at all points. The important messages were very clearly conveyed. Congratulations. Thank you, sir.
Yes. Actually, you have to look at the system. Why it's not the individual,
Yes.
it is the system which, like for example, I was thinking about the hypothermia. There it doesn't happen because automatically everybody is rewarmed and there is a Foley catheter with the temperature probe and they are monitoring all trauma patients. And the trauma patients, the temperature there is already elevated, no AC. So it doesn't happen.
there.
So they automatically rewarm and what is the temperature, and they immediately, a hot blanket and all these things. They are very cognizant about its temperature is like a vital sign, right? So they want to make so that is how you have to make a system so that nobody misses it, because when you are dealing, as you said, with thoracostomy, a lot of bleeding, you will not be thinking about temperature. The nurses and other people have to be. And another thing is there is too many distraction. I go and ask the history, then the cardiologist is on the phone, you get distracted, you are checking the labs, and so there are so many distractions that you are prone to make mistakes. And handover, like important patients, when you are doubtful, you have to make sure that you tell your colleague that I am not sure about the diagnosis. I want you to, examine this patient again and reassess it because I am worried about this. That you have to tell. Otherwise, they don't know. They are like coming fresh. They have so many sign-outs. They may not concentrate. What you are worrying, you have to convey it. Sometimes I take them to the bedside and introduce the patient. If there are like 2 or 3 very serious patients whom the workup is not complete, and my thought process is very important because the sign-out turnover time is okay. Good.
Thank you, Dr. Vinayak, for that thought-provoking and intellectually stimulating presentation. Your insights encourage us to continually refine our diagnostic thinking and learn from every clinical encounter. We now move toward a topic that highlights procedural excellence in emergency care. When performed effectively, nerve blocks can significantly improve pain control and support stabilization in critically ill patients. Stabilizing the unstable. The role of nerve blocks in emergency ABC management. Let's welcome Dr. Gunasheelan Rajendran, Assistant Professor at AIIMS Madurai, to explore the topic.
Okay. So good evening, everyone. People at the back, if you can please settle down somewhere, we can start the discussion. So I was given the topic stabilization of airway, breathing and circulation using nerve blocks. But as you all know, we are in an era where dramatic changes happen, and we are going to put an X before the ABCD always, right? So I have slightly tweaked the topic: stabilization of unstable, the role of nerve blocks in emergency XABC management. Okay. So we will go one by one. In which scenario in X we can use nerve blocks, in which scenario in A we can use nerve blocks, in which scenario in B we can use nerve blocks, and in which scenario in C we can use nerve blocks. Before proceeding, I would like to know how many of you are routinely using nerve blocks in your emergency department? Arihant, yes. Tirunelveli Medical College. You are from? You are from? Tirunelveli, yes. Okay. Anybody else? Okay. So I was also like you before, during my residency. Okay, we never heard of what is nerve blocks, and quite frankly, if we say, we never bothered about pain only. Most of the emergency physicians never bothers about pain. How much ever the patient shouts, you focus mainly on your ABCs and you never focus on the pain. Okay, but if you see, if you control the pain of the patient, okay, they will be more than happy. Even when you control the ABC, they will not be that happy. But if you control the pain of the patient, they will be more than happy, right? So that is where your nerve blocks or your procedural sedation, all these things comes in. And we can also use nerve blocks in life-saving conditions. That is what I am going to discuss today. So imagine a scenario. There is an exsanguinating external hemorrhage. What will you do? Is the ATLS guidelines, the new guidelines say, apply direct pressure, yes, then package, wound packing. Even with wound packing, it is not controlling. Tie a tourniquet. Okay, the tourniquet can be both a normal tourniquet or a junctional tourniquet. Okay, so how many of you have had tourniquet being applied on yourself, like at least for training purposes? Like, so we run a program called as Jeeva Raksha where we tie tourniquets on each other. So how many of you have had tourniquets tied? Manish, is it painful or is it painless when you apply tourniquet? Very painful. Okay, so when you apply tourniquet, it is going to be very painful. We will think that we have applied the tourniquet, we have stopped the hemorrhage and we have saved the life of the patient. But actually the patient thinks, what this doctor has done, it is so painful for me. Instead of treating me, he is giving more pain to me, right? So what we can do in that scenario? Can you give a procedural sedative in this scenario? Already the patient is hemorrhaging. Already there is hypotension. Most of your procedural sedative drugs are going to cause hypotension. So in this scenario, what we can do, we can use nerve blocks to relieve the tourniquet pain, the pain caused by tourniquets. Okay. So imagine this scenario. Below knee amputation, a tourniquet is applied, severe tourniquet pain. You give initial doses of fentanyl, but still the pain is not controlling. Okay, you are worried that the repeated doses of fentanyl can either cause hypotension or respiratory depression. Okay. So if there is an upper limb tourniquet, how many of you attended the nerve block workshop? Yeah. So if there is an upper limb tourniquet, what is the best nerve block that we can use? Which is the spinal anesthesia of the upper arm? Supraclavicular brachial plexus. Okay, that's the best brachial plexus block that we can use for an upper limb tourniquet. Okay. If it was a lower limb, so this is an example of a supraclavicular brachial plexus block. So ideally, you put the probe at the supraclavicular fossa parallel to the clavicle, identify the subclavian artery. So this is a subclavian artery here. If you see this image, this is subclavian artery. The plexus invariably lies superior and lateral to the subclavian artery. And here we are blocking the truncal levels of the brachial plexus. You have the upper, middle and the lower trunk. Okay. So this is an example of a supraclavicular nerve block being done in the emergency department. If you see, there is injection of local anesthesia here as well as here. Okay. For lower limbs, what is the best nerve block we can use for a lower limb tourniquet? There is no single nerve blocks that can be used for a lower limb because you need to block the anterior as well as the posterior aspect. So for anterior, we can use a femoral nerve block, and for posterior, we have to go for the sciatic nerve block. Okay. So coming to airway, this is one area where nerve blocks are very, very less frequently used. And to be honest, I have never used an airway blocks. Okay. For this talk only, I learned about this, how to use an airway block. So when are we going to use an airway block? Yes. So you are afraid that if you sedate the patient, you will not be able to establish an airway. So you want to keep the patient awake, but you also want to establish an airway. Okay. Most likely in epiglottitis, okay, any retropharyngeal abscess, okay, in those scenarios, we may go for this awake intubation. Okay. So there are various techniques with which we can do awake intubation. The most commonly described techniques are aerosolization of local anesthesia. Okay, you aerosolize local anesthesia and inject it into the posterior pharyngeal wall, base of the tongue, and the vocal cords. Okay, instead of that, we can also use a nerve blocks. Okay, so let us discuss about the nerve supply of the airway. Okay, so if you see the tongue and above the epiglottis, the airway is supplied by the glossopharyngeal nerve. Okay, from epiglottis till the vocal cord, the airway is supplied by the superior laryngeal nerve, and below the vocal cords, it is supplied by the recurrent laryngeal nerve. So these are three nerves we are going to target. So we are going to target the glossopharyngeal nerve, we are going to target the superior laryngeal nerve, and we are also going to target the recurrent laryngeal nerve. So how are we going to do this? One is we are going to do the glossopharyngeal nerve block. Second is superior laryngeal nerve block. Instead of blocking the recurrent laryngeal nerve, we are going to instill the local anesthesia into the trachea, eliciting a cough reflex, wherein the patient himself distributes the local anesthesia below the level of vocal cords, in full of the trachea. Okay. So glossopharyngeal nerve is located deep to the tonsillar pillar. Okay, glossopharyngeal nerve is located deep to the posterior tonsillar pillar. Okay, so that is the area where we are going to do the nerve block. So for this, you need a long spinal needle. Okay, a long spinal needle, various syringes, your local anesthesia solution, and the most important thing here we require is a tongue depressor, or we can use a laryngoscope. Okay, so laryngoscope, if you use laryngoscope as a tongue depressor, it is also going to provide a light source for you to aim at the target. Okay, so if you see here, this is the anterior tonsillar pillar and that is a posterior tonsillar pillar, and you see the glossopharyngeal nerve is running parallel to the posterior tonsillar pillar. So that is where we are going to target. Okay, so you need a long spinal needle for this so that you can reach the target. So this is glossopharyngeal nerve block being performed. So they are using the laryngoscope. See how it is illuminating the posterior tonsillar pillar. So it is also providing excellent visualization. And then they introduce the needle just behind the posterior tonsillar pillar, aspirate for any blood or air. It is very important here to aspirate. Why? Which structure is very close to the posterior tonsillar pillar? Internal carotid artery. Okay, so accidental injection into the internal carotid artery can be devastating. Okay, and also the trachea, sometimes the needle can go inside the trachea. Okay, so you have to aspirate and confirm there is no flashback of blood, or what is there in trachea? Air. Okay, so you should confirm that there is no air coming back, free air, and blood coming back. Okay, so that is important with regards to glossopharyngeal nerve. What about superior laryngeal nerve? Okay, so superior laryngeal nerve is, it always passes the hyoid bone. Okay, the greater cornu of the hyoid bone. So that is a landmark, the greater cornu of hyoid bone. Okay, can everyone feel their hyoid bone? Yes. Can we reliably identify the greater cornu of hyoid? Yeah, no, it is a little difficult, right? So what can we use to identify? Ultrasound. Yes. So if you see here, so this is the thyroid cartilage, this is the thyroid cartilage, and this is the greater cornu of hyoid. Okay, so the probe is not kept in the midline, the probe is kept slightly lateral so that we can locate the greater cornu of hyoid. So what we are going to do is, we are going to introduce the needle in this thyroid membrane, and below the thyroid membrane we are going to instill the local anesthesia. Okay, so here they are using an out of plane approach. Okay, instead of an in plane approach, they are using an out of plane approach. Once you hear the pop, okay, that means you have penetrated the thyroid membrane, and after that, yeah, you can instill the local anesthesia. It spreads under the thyroid membrane and blocks the superior laryngeal nerve. Okay, now this is the third thing. Okay, so you puncture the cricothyroid membrane and instill local anesthesia into the trachea directly with sufficient force that it irritates the posterior tracheal wall, eliciting a cough reflex. So here cough reflex is good. So you inject it with force so that the cough reflex disperses the local anesthesia below the vocal cords and into the trachea. Okay. So these are the 3 nerve blocks that we are going to use for awake intubation, preferably using fiber optic. Okay. So whenever we talk about awake intubation, it's always better that we go with an awake fiber optic intubation rather than a laryngoscopic intubation. But for laryngoscopic intubation also we can do this. The only issue here is we are going to put the blade on the tongue, so we may need to apply a lignocaine jelly on the tongue. Okay, so the mucinous lignocaine jelly that we use, we are going to apply it on the tongue if you are going to use a direct laryngoscopy. So this is with regards to blocks that can be used for airway. So glossopharyngeal nerve block, superior laryngeal nerve block, and transtracheal block. Next comes breathing. Yes, so what blocks we can use for breathing? This everyone should be able to answer. Yes, serratus anterior plane, erector spinae. Okay, so how many of you have seen or at least knew that there is something called as an erector spinae block and a serratus anterior plane block? How many of you have given? Yes, there are quite a number of people on the back also. Okay, so it's one of the easiest nerve blocks to attempt. Okay, why? In what conditions we are going to use this nerve block? Patients with rib fracture. Okay, if the patient also has pneumothorax, it's very easy, because even if you advance the needle into the pleural cavity, already there is pneumothorax, you are going to place an ICD anyhow. Okay, so you are not going to cause any more harm. Okay, so I urge every resident to attempt this serratus anterior block in patients who have rib fracture and pneumothorax, where already either an ICD is placed or you are going to place an ICD. Okay, so where will you place the probe for serratus anterior plane block? Yes, so most likely in the 5th intercostal space. So 5th intercostal space, and the anterior axillary fold obliquely you are going to keep the probe. So you want to see this. Okay, you want to see the latissimus dorsi joining into the axilla. Okay, you want to see this structure, the latissimus dorsi tapering down. This is the ideal view with an artery exactly in the center. Can someone identify this artery? Thoracodorsal artery. Okay, so thoracodorsal artery in the center with latissimus dorsi tapering down will be an ideal window. So below the latissimus dorsi you have the serratus anterior muscle. Okay, so here at 2 levels we can block. You can block between the latissimus dorsi and serratus anterior. We can also block between the serratus anterior and the rib. Okay, so most people suggest blocking between the rib and the serratus anterior. Okay, because the spread of the local anesthesia is even there and it spreads way down rather than between latissimus dorsi and serratus anterior. So this is a facial plane block. So in a facial plane block, what should be given more preference, volume or concentration? Volume. Okay, so here don't focus on the concentration. If you take 10 ml of lignocaine or 20 ml of lignocaine or 10 plus 10 ml of lignocaine plus 10 ml of bupivacaine, add more volume by mixing either normal saline or 5% dextrose. Okay, so once you do that, inject close to 40 to 50 ml of the volume so that it spreads evenly. And what we are going to achieve is these facial layers will separate like a zip opening. Okay, so that is what we are going to look for. So as I told, so there are 2 levels we can block, but make sure that you are not injuring the thoracodorsal artery. Okay, or make sure that you are not instilling local anesthesia inside the thoracodorsal artery. Okay, then comes the erector spinae plane block. Okay, again one of the easiest plane blocks to give, but the problem here is positioning of the patient. Okay, patients with rib fracture, patient who is already having pneumothorax. Okay, may not be able to sit up, okay, may not be able to turn. So that is the challenge here. Otherwise the window and giving the no block is very easy. The challenge here is positioning of the patient. Ideally, if you can make the patient sit up like this, okay, you go from the posterior, put the probe in the center, find out the spinous process, then go laterally, slightly laterally, and find the transverse processes of the spinous process, okay. Just above the transverse process will be your serratus erector spinae muscle. So what we are going to do, again we are going to come from here, go and hit the transverse process, okay. Most of the people does not do this. Go and hit the transverse process and withdraw 1 or 2 mm back and then inject the nerve. So ideally what will happen is the erector spinae will lift off from the transverse process of the vertebra, okay. That is what we want. You see here, so this is the transverse process, this is the erector spinae muscle, this white layer. So the muscle lifts off and the local anesthesia spreads evenly across, okay. If you see below also, you can see the blue color solution is the local anesthesia, which is spreading evenly across the below the erector spinae muscle. Yeah. So refractory ventricular tachycardia, we discussed about this extensively in the morning paper discussions as well. So how many of you have seen refractory VT or electrical storm or a VT storm? Yes. So how will you define this? More than how many episodes? More than 3 episodes of VT not responding to cardioversion, okay. So that is what is termed as electrical storm. So what are we going to do next? Yeah, if it is an ACLS scenario, first stop giving subsequent doses of epinephrine, because the epinephrine is the one which is causing this. And then we are going to target a sympathetic blockade, first chemically by giving beta blockers, okay. Esmolol is an ideal agent. If esmolol also fails, then we can go for a nerve block which is going to block the sympathetic chain, that is stellate ganglion block, okay. In India, unfortunately, esmolol is not available in many places, so some people directly go for this stellate ganglion block, okay. Yes, so now double sequential defibrillation or double sequential synchronized cardioversion also is coming up, okay. We can, as sir was telling, we can use both. The patient is in cardiac arrest, we can use a double sequential defibrillation. The patient is stable or having pulse, you can use a double sequential synchronized cardioversion, okay. So for stellate ganglion block, where are we going to inject the local anesthesia? What is the landmark? Yes, so just above the C6 vertebra, just above the C6 transverse process, just below the carotid artery, okay. So basically carotid artery, IJV and your sympathetic chain lies below this carotid sheath, okay, carotid artery. So your target is going to be depositing local anesthesia below the carotid artery, okay. So you can see here the carotid artery, below the carotid artery is where you are going to deposit the local anesthesia. Of course this is going to be difficult in a cardiac arrest scenario, because there is somebody who is going to do chest compressions, there is somebody who is going to do a bag and mask ventilation, okay. Ideally you should turn the neck slightly so that the access is easy, but because somebody is giving a ventilation, okay, so you may not be able to turn the neck, okay, unless the patient has an endotracheal tube inside. Otherwise you need to keep the neck in the neutral position and then try to insert the needle below the carotid artery and inject 5 to 6 ml is enough actually here. Yeah. So this is the C6 transverse process, okay. C6 transverse process has this peculiar saddleback appearance, okay, because it has an anterior tubercle and a posterior tubercle, so it has a peculiar saddleback appearance. Just lateral to it is the longus collae muscle. Between the longus collae and the carotid artery is where we are going to target our this thing. So you can see the in plane approach, they are bringing the needle from lateral side, going below the carotid artery and injecting the local anesthesia. we have discussed extensively about nerve blocks, but whenever we are going to perform nerve block in the emergency department, we should be always worried about local anesthetic systematic toxicity. Okay, accidental injection of the local anesthesia into an artery will produce something called as a local anesthetic systematic toxicity. What is the earliest clinical manifestation of last? Perioral numbness. Very good, everyone knows this, perioral numbness. So what should you do? Okay, stop giving the drug. Then intralipid. Okay, so how many of you have intralipid in your emergency department? Yes. So the moment you start thinking about doing nerve block, it is always imperative that you keep intralipid in the department. Okay, go to your anesthetist, ask for intralipid and bring it to your department and keep it there. Okay, because if you experience last, you need to immediately give intralipid. Okay, the other thing about giving nerve blocks is safety. Okay, so many regional anesthesia societies have given clear-cut guidelines on safety regarding regional anesthesia, and the current recommendation is what we call it as a triple safety. Okay, a triple safety for giving nerve blocks. What is this triple safety is? You are going to use ultrasound to visualize the needle tip, then you are going to use a nerve stimulator to see whether you are just at the perineurium or whether you are inside the nerve, and we are also going to use a simple device which is called as a injection pressure monitoring device. Okay, so this is connected between the needle and the extensor tubing. So what we'll do is we'll just see how much pressure, when you push the drug, how much pressure is there. Okay, a pressure of above 15 to 20 psi, definitely you should be worried. Okay, so you may be inside the nerve. Okay, when you inject the nerve inside the, when you inject the drug inside the nerve can swell and can rupture. Okay, so and that can cause permanent nerve damage. So it is imperative that we use a triple safety. Okay, of course many of us have ultrasound, so one of the safety is checked. Okay, it is very easy to get this injection pressure monitoring device. Okay, the only problem is getting a nerve stimulator. Okay, and how to correctly use it. Many of the anesthesiologists uses this very frequently. Even before ultrasound was there, they use nerve blocks using nerve stimulator. So maybe we can go and get trained from them how to use this nerve stimulator and use this overall triple safety net for nerve blocks and regional anesthesia. So nerve blocks can be an adjunct to ABCD, but use it judiciously and cautiously. Know the EM indications. Again, the problem nowadays is we are learning nerve blocks from anesthesiologist colleagues, but they always talk us with regards to operative indications. So for this surgery we will use this block, but what is the EM indication for using that nerve block? So that we should be able to know, or we should at least derive our own indications. So if this condition, for example, a shoulder dislocation comes, I will be giving an interscalene nerve block. Okay, interscalene brachial plexus. Like that we should be able to derive our own indications for our nerve blocks, and then use the triple safety methods for regional anesthesia. And if you are routinely using nerve block, keep intralipid in your department. Okay, yeah. Thank you very much.
One thing is intralipid is very important because in 2006 I was a final year resident. It's like almost 20 years ago. At that time only they introduced intralipid, like 1 or 2 years before that. We had a patient, we were giving for the hip fracture facial iliaca block with bupivacaine, and the patient went into cardiac arrest. And at that time not everybody were aware of intralipid, and one of the attendings was a toxicologist. So anyway, we did the ACLS and things like that, AP and chest compression, nothing was happening. This patient, that's it, went into like asystole, So he said, okay, let us give intralipid. This was like 10, 12 minutes into the cardiac arrest. We gave intralipid, QRS came. It's amazing. I was like, I didn't know it is this effective. So I am just telling you, it's like a miracle drug. So that's what I'm saying.
Any questions?
So, there is always this difference of opinion in case of a trauma patient when we are giving a nerve block. Suppose there is a trauma where there is high risk of compartment syndrome. So should we still prefer giving a nerve block to that area because it might mask the pain for us to identify compartment syndrome later?
I will answer that question with what Chandni madam and others discussed yesterday. What will you want in that scenario? If you are the trauma victim, will you want a nerve block for your pain?
I will want a pain.
Yes, right? Okay, so compartment syndrome, there are many other ways to identify compartment syndromes. Okay, so just because pain is an early indicator of compartment syndrome, keeping the patient feel that pain is not a right way, is what my opinion will be. Yes.
So which fracture you are bothered about compartment? Okay, so where are you going to give the block? Yeah, so how much you are going to inject?
15 ml.
Yeah, 15 ml. Yeah, so the thing is, you can feel the compartments, whether it is soft or not, and all those things, you know. And there are other ways, yeah.
So we are going to mainly target analgesia. So maybe the patient may not experience pain, but on passive stretch, the pain will definitely be there. So the motor. But the problem is the popliteal nerve block for a both bone fracture is again positioning the patient. Okay, so you need to prone the patient for the block. So with a fracture in situ, proning the patient becomes very difficult. Any other doubt? Neeraj.
Just wanted to know if is there any role in leaving a catheter in place after performing the block? Basically, some of those patients will have pain after some time. Again, depending on the agent we use for the anesthetic drug, is there any role? Because I had this conversation with some anesthetists, and they are also like a little gray. So, as an ED physician, what is your take on this?
So in the emergency department, it is preferable to avoid the catheters because for catheter to be in place and for it to successfully work, we need a stable patient. Stable patient in a sense, the patient should not be moving around, or we are going to shift the patient to there. Preferably the patient settles down in the ICU. At that point of time, we insert a catheter, it will remain in place. So in the ED, if we insert a catheter, the problem is when we shift the patient around, it can get displaced. So I will not, from my experience of not placing a catheter for regional anesthesia, but from transvenous pacing. So we do a lot of transvenous pacing in the emergency department in JIPMER because of yellow liver poison patients. So quite often we encounter the pacing lead getting displaced when we shift the patients. So we have I devised a novel way to fix that also, but still it gets displaced. So similar to that, the catheters may also get displaced. So it's preferable that once they go to the ICU or a ward, then there they can place the catheter. That is.
There they will put the epidural catheters and everything. The anesthetist will come and place the epidural catheters.
So if there are no questions from the residents, I am going to ask one question to the residents. So we are going to use lignocaine as a predominantly local anesthetic agent, right? So then why are we worried about last? Lignocaine is a drug which is indicated for VT or something. We are giving for VT, right? Then why are we worried about last? So in that scenario, last won't happen when we. Yes. So that lignocaine is different, and the lignocaine that we are going to use for local anesthesia is different. The lignocaine that we are going to use in VT is what is called as a xylocard, which is not with preservative. Okay. Whereas the lignocaine that we are going to use in local anesthesia is with the preservative called as methylparaben, and that is the toxic agent not the lignocaine. Okay. Yes. Thank you.
Thank you, Dr. Gunesh.
You don't use long-acting ropivacaine or something like that, which lasts for 12 hours? Yeah, most. Ropivacaine lasts more longer, like 10 to 12 hours. Bupivacaine is around 6 hours.
Yeah, that is additives, dexamethasone, epinephrine, dexmedetomidine and all, is to prolong the anesthetic duration. Yes.
Thank you, Dr. Gunashilan, for that highly practical and skill-focused session. Your expertise demonstrates how procedural mastery can greatly enhance patient care in the emergency department. As we approach the final talk of the session, we are reminded that emergency medicine is not only about diagnosis and procedures, but also about communication during moments of crisis. In challenging situations, the way clinicians communicate can profoundly influence the experience of patients and families. Beyond medical management, communication in crisis. Please join me in welcoming Dr. Himanshi Bhatt, Assistant Professor in the Department of Emergency Medicine at Himalayan Institute of Medical Science, Dehradun.
Very good evening to everyone present here. And I understand that this is the last session, and this is always usually the last thing, and we try to ignore it also. We are so much bagged with the medical management that we usually forget about the communication bit of it. So that is the purpose of today's talk. And before we begin the conversation, I would like everyone to just share with the person sitting next to you any situation where you felt that there was a difficult communication. It could be any kind of communication in your workplace. We'll take 60 seconds. Anyone who doesn't find a partner can discuss with me. So have we been able to share with our partners what we faced? Now hold that thought, and we'll move to the crux of today's talk. As ED physicians, you can recognize such a scenario where a 40-year-old was reeled in, the patient has come in shock, the patient had a heart rate of 168, a diagnosis of SVT is being made, and decisions are being made. And you can see what all is going on here. Looking at this picture, if I have to describe it in one word, it's mainly chaos. And it's important that in whatever situation our ED is, we know how to communicate with our team first. So some basic aspects of communication with the team require us to know our environment, our team. We need to anticipate for each situation rather than reacting to it when it comes. We designate a clear team leader, distribute our work, fixate our tasks, communicate clearly, call out, confirm, then we close the loop. Use whatever resources we have at hand so that we can effectively talk to our team and manage the patient. Another important concept here is crisis resource management. Initially in the aviation industry this was used because there they had to make these decisions quick, and now it has come to the medical field as well. So core concepts here are to designate a clear leader, then call for help when required, anticipate and plan, know your environment well, then use all the available resources you have, allocate roles and attention wisely. It cannot be a one-member led management when we are working in the emergency department. Use all cognitive aids and resources that we have, distribute the workload equally, and establish the clarity of roles. Very important, very small but usually skipped step is closed loop communication. Closed loop communication requires the sender to clearly state the task. It requires the receiver to repeat back that I have understood the task, and then the sender confirms that yes, whatever I tried to convey was truly conveyed to my receiver or not. I hope the last bench can hear me clearly. I hear that they can hear me clearly. So you see, this was a closed loop communication we just demonstrated. So it's important even in the ED that we do this every time. The commonest example that you all know is adrenaline 1 milligram IV during a cardiac arrest scenario, and the staff supposed to repeat back that we have given this much adrenaline, and you confirm that yes, you have given that adrenaline. Just communicating by talking is not enough. It is important that we communicate by the verbal cues, by our body language, by all the environment that is around us. So the concept of situational awareness bears very important role for emergency physicians. It's important that we perceive whatever we are doing, whatever is happening, why that's happening, rather than just that it is happening. Then we have to identify why it's happening, comprehend it clearly, and then whatever intervention we are doing, what will it create, what will happen next, project whatever decisions you're going to make, how will that impact the patient. Take a simple example of an intubation where the patient is in shock. You are bothered about intubating, but you forget about managing the shock. What happens? You give the sedative, you give the induction, relaxant, and the patient crashes. So here, if we had the perception and we comprehended things clearly, the projection and whatever our actions will do in one situation and the other would be life-changing for the patient. So the chaos that happened on that patient, inadvertently the patient arrested, and this doctor tried to give the message to the wife, and this is what happened. She fainted right there. The doctors got confused now how to handle the situation. So here comes the importance of knowing how to break bad news in the emergency department. We all know about the spikes protocol. It is the gold standard. We know that we are supposed to keep a proper setting, set up a private space. We should sit down with the patient and talk. Then we have to understand how they have perceived the scenario, find out what they know, what do they expect from us. Then we invite them how much they want to know. Then we give them the knowledge. So whenever we are sharing knowledge with them, it has to be done very curtly. First, we have to warn them. Without warning, you cannot just start with your chunks of knowledge. Anyone should know whether they are heading towards bad news from the outset itself. So first thing is to warn them that whatever this communication will be is not going to be good. It is a bad news. Again, we cannot say this way, that it is not going to be good. That is what we end up doing. We always say, he is no more. This is a commonly done thing whenever we are trying to explain death. But we want to make sure that we are using direct words here. Another is small chunks. Give them information. Maybe after each 3 lines, you check back whether they've understood. Do not use medical jargon. Then demonstrate empathy throughout the communication. Most importantly, we need to know how to handle the silence. Because when you are giving a bad news to a person, it may take time for that person to understand and for that message to sink in. So we need to, instead of trying to fill that gap of silence, we need to embrace it and listen. Wait for a few seconds till that person holds back their composure. Next, strategize and summarize in the end. Okay, so we know about the spikes protocol. But in our ED, can we really do all of these things? How many of us have a problem about private space? Do you truly move to a private space to give to counsel such patients? I have a problem. My ED, I have 5 patients standing there. I have to manage them. I have to break this news. The counseling room is towards the other end of the ED. It is very difficult at times.
Otherwise, you are not doing a good job. This is very important. Imagine, this is like human death, you are going to say, very traumatic. We have to see how we are in that situation, that person's situation. We have to spend some time, It's not like it is not always the drugs or anything which is important. Sometimes the communication, the tone, the choice of words and tone is much more important than any drug you are giving to that patient.
Yeah. The other thing is language barrier. So this is a mixed population. I am talking in English and I am telling you the spikes protocol. It's very easy to say those words as is. But when we come to vernacular, Converting it directly becomes difficult. We are unable to find words. Some of us are probably working in a place where the vernacular is much different than what mine is, and I'm not able to, convert a present tense to past tense, and those things make a lot of difference in communication. The large family groups that are there around the patient in our EDs, the time pressure, of course you have other patients, then the cultural expectations here in India are different. Here the family comes before. There are so many patients who won't even know about their diseases. The families don't even tell them till the very end. Then of course we have declaration of death, which is very important. When Spike's protocol was made, it was not exactly catering to declaring death. So certain emergency department adaptations have come into place now. There is this grieving protocol for death notification specifically for the emergency physicians. Here what we do is we gather all the family members to a private space. We use whatever resources as we have. As sir was just saying, you can ask any staff to just take the patient to a private space. We may not have a room, but you can curtain off a small area in your ED. That is easy to do. Next, we identify ourselves. We identify that the patient's relatives are the same that we want to counsel. We briefly explain every event that happened which led to that. Then we verify again whether they've understood whatever we wanted to say. Then we give them that space. That space is purposely there. You give that space for the thing to sink in. Allow that time. Then we inquire for any questions that they may have. Then we discuss about other options. That is termed in nuts and bolts in this grieving protocol. There's your organ donation, there's autopsy, then any other next steps. And finally we give up condolences, we'll give follow-up or our card, whatever suits that situation. For the Spikes protocol also in 2024, Rivera et al., they have tried to modify the Spikes protocol also according to the emergency department. So specific changes that were done was suggested by them was in the settings where you can create a private space by either curtaining off in the ED itself. Another was information delivery we give specific to our situation. The emotional response we cannot give as much time to them, but yes, we cannot leave it also. Another is when we are talking about treatment plans in Spikes, it is much detailed, but in ED we should go for a focused approach rather. Done. We are done with the communication and the day moves forward. The consultant comes for round and the senior resident who had just joined this institute 1 week back, she goes and she complains. She's so frustrated that the patient died. So she goes to the consultant and she says, your residents don't even know when to give adrenaline, the patient died, without looking at what was happening. So here again, another communication skill that we need to know, conflict resolution, comes into play. It's important that both the person who has a concern, how the person is putting forth the concern, and for the person who's receiving the concern, how we receive that concern. Many of us here are final years, and you will be soon in that phase where you will be at both ends. You will be the senior resident who comes to the faculty side, and you will be that link between the junior resident and the senior resident. So for us, it's very important to know both the things. So for how to put forth your concern, we have a desk framework where you describe the specific behavior which had bothered you, express how it has made you feel, and then suggest a specific alternative to improve that, and also state the outcome and consequences of the problem that had happened. The person who's at the receiving end should listen actively without interrupting just because they are at a higher authority position. Empathize with the person who is raising a concern, because it's very difficult and rare that people will raise up their concerns. Ask clarifying questions as to what their doubts or what their concerns truly are. Paraphrase and understand what they are trying to say, and then come to a conclusion together. So we have seen team dynamics, how team communicates. Then we've seen a doctor-patient communication. We have seen a senior-junior confrontation communication. And the fourth one is your interdisciplinary communication. However, because the patient died in the scenario, we couldn't move forward with the interdisciplinary communication. So let's revisit our patient in a different situation now. So this patient, the same patient had come, the team was prepared, they had good communication between each other, they managed to do what they wanted to do, they moved forward, they tried to counsel the patient is still critical but has survived, and now the same doctor is providing the information to the patient's relative. Relatively, there is a curtain, there is some privacy, he knows how to express better, told that to the patient relative. The same problem had happened here also, some dose was missed, so the senior resident does approach the faculty again here, and now what they do is they move to a private space, they discuss it throughout, they discuss the whole thing in a methodological and structured way, and they come to the conclusion that both of them are moving towards the same common cause, which is providing the best care for the patient. And finally, because the patient has survived, the patient is being shifted to the cardiac ICU, and here the important communication that comes is your SBAR communication for handing off a patient, where you explain the situation, then the background, whatever you've done, the assessment, the important aspects, and what you recommend for the patient. The same patient, this was the same ED, however, the outcome changed with just better communication. As this was a BREM session, it's important that residents know what they will benefit in the exam. So your DNB, the MD, DNB and the MRChem exams, all of them have communication as a separate skill station. Personally, for my MRChem itself, I had 3 skill stations only on communication. So it's very important. For your DNB and MD exams, long questions come on communication, which include your spikes protocol, the differences between your grieving and spikes protocol, the SBAR handoff, every one of the principles that we've discussed. So I think this is a rather important but commonly missed topic. So we discussed this today here, and I thank you for patiently listening to me because this is the last session. And before I just give the mic off to you guys for doubts, I want you to think whatever situation you discussed amongst yourself at the beginning of this talk, did you learn even one thing which could have changed that situation? You can just keep that answer to yourself, and if that answer is yes, my job here is done. Thank you, and if you have doubts, I'm here to answer.
Excellent presentation. Anybody have any doubts? Its most important thing is practicing, It doesn't come in one day by reading the book. You have to practice it every day, when you are dealing with patient, relatives, your residents and other things.
Thank you, Dr. Himanshi, for that powerful and deeply meaningful presentation. Your reflections beautifully remind us that compassion and communication remain at the very heart of emergency care. As we come to the close of the session, we would like to take a moment to recognize the excellent contributions of our speakers who shared valuable clinical insights and practical approaches that are highly relevant to emergency medicine practice.